I am Raj Kumar, President and Editor-in-Chief of DevX. Really excited to kick off this conversation. You are on the front lines. That is what this conversation is all about. And we have participants joining us really from all over the world, from many countries. And I just want to give you a warm welcome to what I think is a really critical event. I'm based here in the United States, and one thing we see as you travel around are placards in front of houses, which are essentially thanking the healthcare heroes, the community health workers or nurses or doctors or midwives, the people who are on the front lines of this COVID crisis. There's more attention than ever to the importance of their work, to the risks they put themselves through. And yet at the same time, there's really an important conversation that maybe we're not having right now. And that conversation is about, what do we do to empower those frontline healthcare workers? What do we do, first of all, to listen to them and understand their needs? And that's what this half-day session is really all about. And we're really delighted at DevX to get a chance to bring this to you through partners. Of course, we do everything through partners. And in this case, we are delighted to partner with 3 organizations that have a long history of working closely with frontline healthcare workers: Johnson & Johnson, Smile Train, and MSD for Mothers. So my big thanks to those 3 organizations, and I look forward to hearing from them through the course of the day. I look forward to hearing from all of you as well who are joining this. This is an extension of our Duty of Care content series. And the idea behind Duty of Care is really that we all have a duty of care. We're used to using that term for healthcare workers, but all of us, communities, citizens, have a duty of care for healthcare workers. And this content series, which I encourage you to find and check out online, that DevX has put out with a number of partners, really digs deep into what many of us who are in the world of health, global health, and who believe in universal health coverage think is really maybe the most important issue, a critical issue. In fact, the WHO says to get to UHC, 80% of the new investment has to go into the healthcare workforce. And today we have a gap of 18 million healthcare workers in the world. And as I think we can all see in stories, even in the most advanced countries, healthcare workers not having enough personal protective equipment during this COVID crisis. So much of this we're going to get into today, but you can join that conversation as well. Tell us what you're thinking, ask questions. When you're joining us online, there's a Q&A box. You can ask your questions there. We'll look at them throughout the day and incorporate them into our conversations. Of course, we're on social media. You can use the hashtags on the front lines or the hashtag DevXEvent and follow along to a conversation that will have many people engaged in it. We had a Twitter chat last week. We had 400 organizations that were part of it on this topic. So we know there's tremendous interest, and we're glad for that on such an important topic. Before we dive into our first panel, and the first panel is really with global health leaders, we're going to hear directly from them. You're also going to notice throughout this half-day event that my colleagues have spent a lot of time going out and finding the voices of healthcare workers on the front lines, as the session is titled, from all over the world. And we're going to get a chance to hear from them directly. So I want to bring your attention to a particular healthcare worker and invite you to listen to Prasi Muyingo, who is a community healthcare worker supported by Living Goods, based in the Mityana district in Uganda. Let's hear from her, and then we'll go straight to our panel.
My name is Mingo Prose. I'm a community health worker supported by Living Goods in Mityana district. My clients find me at home. I have to keep a distance when serving them. I use PPE, masks, gloves, and sanitizer when distributing posters to sensitize the community about COVID-19. One of the main challenges I have faced is that some clients are not able to come to me when in need of health services, and yet I can't go to them since I have limited PPE. I call upon those in leadership positions to provide sufficient and appropriate PPE for all frontline health workers, including community health workers, so that we can continue to support the fight against COVID-19 without putting ourselves and the people we serve at risk.
thank you for that video and for that message, Prasi, and for all of your colleagues who are working on the front lines at the community health level. Hopefully it gives us all a chance to remember what I think we know, that so much of the healthcare burden falls to community healthcare workers in many countries of the world, and many of them find themselves without basic equipment as we grapple with this pandemic. And of course, the effects are big, even in countries with low numbers of infections. I want to get us started on our conversation with global health leaders. And these are people who many of you know. In fact, our first panelist is someone that those of you who follow DevX, who attend our events, who read our pages, know very well and need no introduction whatsoever. But Dr. Agnes Binagwaho is with us from Rwanda. Agnes, welcome to this discussion. You're, of course, the former Minister of Health of Rwanda. You spent a long career since you went back to the country with your MD and your PhD to work in the healthcare field, rising through the ranks to become minister. After you left, you helped to co-found the, of course, well-known University of Global Health Equity, which I had the honor to visit last year. And you work with partners in health. You wear many hats, including as a senior advisor to Dr. Tedros at the WHO. We always love to get your take on these issues, so thank you for being here. And let me also welcome Dr. Miki Chopra, who leads service delivery at the World Bank in the health, nutrition, and population global practice. Miki, thank you so much for being here. You, prior to this role, were the chief of health at UNICEF and have spent a long career across many of the global health institutions we all know so well. So thank you for being a part of this. And then I see Dr. Emmanuel Capobianco is with us as well. He directs health and care at the IFRC, the International Federation of Red Cross and Red Crescent Societies. He, at the IFRC, leads their COVID-19 response, as well as the Ebola response in DRC, another crisis we can't forget is still happening. So thank you as well for being here. And I just want to jump right into the discussion. Maybe I can start with you, Agnes, and get your overall take on where we stand. This was supposed to be 2020. Dr. Tedros and WHO said was going to be the year of the nurse and the midwife. Of course it is, but COVID has taken over everything. Give us your take on where the healthcare workforce issue sits in the moment that we're all facing today. And I think you're on mute if you're talking. Let's see if we can unmute Agnes, please. It seems like she is still muted. Not yet. Not yet. Yep,
I hear you. You hear me? Sorry,
we hear you now,
I lost
we hear you.
even. That's the IT mystery. I don't want to question my computer. But, it has to be still the year of the nurses because they pay a huge tribute. And if we go to the fact that the health is a human right, everybody is entitled to that because they just exist. So we all accept that access to medical assistance when you are sick is a human right. So it is a moral obligation for clinicians, nurses, doctors, community health workers to serve the patient when there is a need. And during pandemic like this, there is a huge need. But the problem is that if they are not protected, I talk about the nurses, the doctors, the community health workers, the lab technicians. If they are not protected, they may die. And there are so many victims of the service because not enough PPE, not enough masks, or wrong message, or really not caring about them. The year of the nurses. So I'm still shocked with what happened in countries that can afford. Some country maybe are not able to afford, but the majority of the country, it's not the case. And they say it happened by surprise. No, the big peak out of China came 4 months after. So their country were prepared and their country were not prepared.
And Rwanda fortunately falls in the category of a prepared country. At least so far, the virus has not grown too much in the country. You stopped very early. You very quickly had a lockdown, stay-at-home orders, and the country seems to be doing very well in comparison to many others, especially here in the United States, which leads the world in infections right now. Agnes, let me bring in a couple of our other voices. I want to come back to you in a moment, but Mickey, maybe we can turn to you at the World Bank. Anya said it's a moral obligation, and yet she's right. So many countries haven't been able to provide PPE. They haven't been able to, even before this pandemic, expand their healthcare workforce in the level required by the demands, especially of growing non-communicable diseases. Many community healthcare workers in the world still aren't paid. They don't get a formal wage. How do you see this issue of healthcare workforce that you work on all the time before the pandemic? How do you see it affected by this pandemic?
Yeah, Raj, that's a great point. And sometimes we forget this, that the pandemic, as Agnes has said, in many ways has just amplified the fault lines that were there before the outbreak. And, it's no surprise that countries where the investment in health workers has been too little and too low, and the trust between health workers and management and employers has been shaky, have been the countries which have really seen the system most fragile. And so I do think it's right to draw attention to these pre-existing conditions, if you like, that are making some systems more vulnerable. And as you indicated, it does range in the first instance to financing. And an issue which I want to bring to the table as well is the real concern we have that even before the outbreak, that the financing conditions in many countries was very fragile in terms of debt, high levels of debt of many countries. And then now with this outbreak and the recession, the fiscal space for investing in health workers has become more and more endangered. And so I do think the role of an organization like the World Bank is first and foremost is how to expand that priority given to healthcare workers and the health systems in the context of really tightening budgets and tightening fiscal space. As you may know, we've sort of started with at least getting about $160 billion out in terms of grants and concessional loans on the COVID response to about 100 countries. But that's just the start. It's then translating those finances and resources into equipment, but perhaps most critically into behavior changes as well, is how to build that trust in the system and with the health workers as well.
Yeah, and it's kind of ironic because you're saying correctly that right now many countries say, hey, we don't have the fiscal space, our economies are in recession, they're heading down, and probably what they've lost in their economy is more than what they could have just invested into having a stronger health system to begin with that would have mitigated such a severe economic impact. And in the end, even numbers as big as 160 billion could look very small compared to the scale of the economic devastation that this causes.
Exactly right, Raj. Yeah. So how do we make that investment case stronger and more powerful and amplify that voice that you've got sort of through the DevEx partnerships, for example?
Yeah, Emmanuel, you were grappling with Ebola in DRC. Like a lot of other disease areas, this is one that got a lot of attention in the beginning. Then the public attention started to fade. Healthcare workers in that country were under attack in many cases. The situation was really difficult, still is. What lessons are you drawing from that and from the pandemic at this point?
One of the first lessons is that you can't control an epidemic without having the people with you. This was very clear in Ebola in DRC on the East Front in North Kivu, where we did have vaccines, where we did have a treatment in place, and yet it took us 2 years to bring that outbreak to an end. You transfer this into our reality and you see that we have less weapons, but still you can contain a lot the outbreak if you bring people with you. And that is happening in some places with the right combination of harmonization of politicians, scientists, and media coming together. It's not happening in other countries. One of the critical elements for us in the Red Cross is epidemics need to start with people and will end with people, and people needs to be kept at the center throughout. And that's where I think one of the biggest lessons from Ebola and from this is the importance of community health. We have talked a lot about doctors and nurses in hospitals. These are the heroes, and rightly so. We have talked less, and I'm glad that you showed the video about our community health workers in Uganda. We have talked less about the frontline health workers, about the challenges they face. And it's not only the physical protection of masks and PPEs, it's also the psychological protection. The amount of stress that they have endured, that are enduring, is enormous. It also, the financial protection. Many of those ones are there risking their lives without hazard pay, without health insurance, without death insurance, and they are out there compromising their own, risking their own lives and the lives of their own families. We need to reconsider that for the future, and bring that now to the center of our policy discussions for managing this pandemic, but also preparing for future pandemics, future global health challenges that will require a very strong community health basis to respond.
Yeah, it makes me think of the West Africa Ebola crisis and the importance of just getting pay into the hands of the healthcare workers, using cell phone, mobile money, because in the end, healthcare workers themselves and their families can be very vulnerable to the virus or to just the economic repercussions. They need to eat, and if you don't pay them, what are they supposed to do? Agnes, I wonder what your take is so far in the conversation. When you've been in all these global fora, I see you all over the world pushing governments, pushing the international organizations to make investments in healthcare workforce or in healthcare systems in general. And now here we are talking about trillions of dollars of stimulus. The European Union just passed 800 billion euros. The US government's talking about another $1 trillion package. All this money sloshing around. Is any of it coming to the places that you know so well, like where the University for Global Health Equity is based?
I'm even not sure. I don't know how to trace this money, but I'm not sure that it's going at the right place to do the right thing. And what has been said before, that if this money have been invested in 2003, there was a great Lancet Commission on investing in health, showing how the investing in health even accompany development, and is a big portion of development. Every dollar invest in health, but with equity. We have to be careful what you meant when you say investing in health. And I totally agree that health starts at community level, where the people live, in household, in a village. And if you invest the right amount, and it's sometimes not so much compared to what is planned, but they are not considered. And we talked also about trust. Investing in ICU, we all need ICU, all countries need that. But investing in community health allow a country like Rwanda that has only 5 deaths, and among them 3 coming from outside, too late, to perform as we have performed, investing in community health, be prepared with your infrastructure, and also be responsible of your job. When the China was screaming, it's dangerous, we start to work in January, got the first case in March, and be ready to tackle it. Other countries knew they didn't move just because there is a bridge in accountability. So no, the money doesn't go where it has to go. And there is no accountability, there is no financial accountability, and there is no long plan development of the world.
Yeah, this is obviously a major systemic kind of a challenge. We at DevEx, we had produced a report in partnership with PATH back in 2017, where we interviewed a number of people, including Dr. Anthony Fauci, the US lead doctor for infectious disease, and said, what are you most worried about when it comes to global health security? And the number one issue that everybody, 40 people we interviewed, all said was a respiratory influenza-like pandemic and how dangerous this would be for the world. And yet, it was all a big surprise, and we keep hearing the word unprecedented. The global health community says, no, we knew this was coming eventually. We didn't know when, but we knew it would come, and we needed to prepare for it. Clearly, we haven't quite gotten there. Mickey, you talk to a lot of the health ministries in the world, people like Agnes in her former role. What are you hearing from the health ministries? Do you think things are different this time because of the pandemic, in terms of the way they view their health workforce the investments they might make? Has something really changed in a more fundamental way?
Yes, I mean, two interesting things which are coming through quite clearly. One is the recognition that the supply chains to provide these PPEs and to provide the infrastructure are broken and have been much less resilient than people had thought. And so I think there's a recognition of the need to not just invest in safety and health workers, but also that how vulnerable we are to these global disruptions. And so I do think one of the recognitions has been to not just look at it from within the health sector, but engage with the trade ministry, with so in Ethiopia, for example, we've been having discussions about giving tax subsidies to the textile manufacturers to produce PPE, to waive the import tax on cotton and things for production of PPEs. So I think there's a recognition that this goes beyond just the Ministry of Health, and that there needs to be a more joined up thinking of how to tackle this issue. I think the second recognition, which I suppose is a little bit of a dirty little secret in global health, and ministries of health are recognizing this more and more, is that actually in some countries, the terrible quality control and infection control in health facilities is actually a major cause of spread of the disease, and the lack of both sanitation and water facilities is scandalous, but also that the infection control procedures in many health facilities across the world are just not being adhered to and have never been adhered to properly. So I think there's also a recognition that this is not just a nice or good thing to do, but an essential thing to do to control this outbreak. And so I think this sort of combination of the importance of this, but also some of the non-financial challenges are also becoming higher on the agenda.
Yeah, one of the articles you'll see on our Duty of Care content series mentions that 55% of health centers in low-income countries don't have access to clean water for hand washing for healthcare workers. It is, the word scandalous is absolutely right, Mickey. It's shocking that we could be, even before a pandemic like this, in such a situation. And then you wonder how they're meant to follow infection control procedures and how they're meant to be hygienic in a situation like that without such basic facilities.
Absolutely, and maybe something we'll come on to, Raj, but this then has secondary effects, because then the population, as Emmanuel was saying, as we saw in the DRC, loses confidence, quite rightly probably, in going to the facilities. And so we're going to see these second wave effects of increases in non-immunized kids, in maternal deaths. It took Liberia over a year to get back to its Ebola situation in terms of maternity and institutional deliveries, for example. And that was with huge investments in the system post Ebola. So the lasting impact of this outbreak could be more than just the direct impacts of COVID, but the loss of confidence of the population, exactly because of this lack of, people see it when they go to a facility, they see that there isn't those infrastructure there, and they're not stupid. So so this is not just about the direct impact, but also the indirect impact and longer term impact as well.
Yeah, you could see that as a subtext of the Prasi interview we did, the community healthcare worker in Uganda, because she's saying, look, I'm not going out because I don't have enough PPE. People have to come to me. Well, that's got to reduce the demand. There has to be a big demand shock. I saw that from one of the participants in our Twitter chat, that a lot of people are just simply not going to healthcare facilities for other kinds of illnesses because they're worried. And I'm sure the number of people she's able to see as a community healthcare worker must have gone down dramatically, and that will lead to less prevention and more healthcare challenges down the road. Emmanuel, I think you wanted to jump in on this point.
Yeah, clearly the secondary impact on health are going to be enormous. In the rich world, we may see that elective surgeries are being delayed. We may see that testing for cancer may be delayed, and that's what we may have seen within our families or of our friends. What is happening in a lot of low-income countries, that immunization efforts are being halted. you have TB patients that are not coming to the facilities, and hence we have projected mortality that is extremely high. And so we really have to face a double challenge right now to respond to COVID, and you have these frontline health workers that need to respond to COVID, while at the same time providing services for the other critical diseases that require primary health care, and that is a massive challenge, and that builds on a basis of limited workforce that then becomes exhausted and then gets into burnout. And that's where I think one of the main outcomes of this crisis will be the realization that mental health and psychosocial support is not a byproduct, is not something that goes really at the last priority, really needs to be put at the very top. That's something that we at the Red Cross are taking extremely seriously. We passed at the international conference in December, the largest humanitarian conference, 2 resolutions. One was about epidemic and pandemics, preparing, and it was called Time to Act. And the second was about including mental health and psychosocial support as part of all humanitarian initiatives for the people who may benefit from the services, but also for the health workers and the volunteers that are involved. And that is something that for us is critical. And we have seen mental health and psychosocial support really emerging as a top priority within the larger priorities of the direct impact of health of COVID and indirect.
I think Agnes wants to jump in on this point, please.
Yeah, I totally agree. And this is in situation of crisis. But this has to be the case in day-to-day work of a country. And what we teach about the staff, the space, the staff, the system, and the support as a basic way to provide care, integrating everything. It's what we call about now we can do nothing if we don't follow the truck drivers. And this is the Minister of Transport, and the custom is the internal affairs and security. So national collaboration, but also international for exchanging the good practice and what happened, and everything community driven. So everything said here should be the day-to-day work of a normal health system and create a system with trust and accountability. So I just want to say that because it's not when there is a crisis that we discover the good principle of global health. They are there, they are known. We are screaming it since years and we are teaching them.
Yeah, I just want to go back to something that Mickey said, which struck me. You know, he's talking about working with the trade ministry in Ethiopia, getting, reducing taxes or tariffs to manufacture PPE. And that's obviously it's going to take time to set up manufacturing facilities. But the reason you would do that is because this is not over anytime soon, right? I mean, the best, Bill Gates was saying just a couple of days ago, I think that the best case is still end of the year for a vaccine. That's the best case. And of course, will that be available in many of the countries we're talking about that are low income? Not for quite a long time. So PPE is going to be needed for a year, 2 years, a very significant amount of PPE as well. And a lot of the systems changes we're talking about, there is still time. In fact, there may be a lot of time that we're still living in this pandemic crisis moment where big change is possible. And so I want to just say that as a prelude to one of the questions, we're starting to get great questions in from the people who are following this all over the world. And one of the questions is, do we need to really think bigger about some kind of a reboot of the overall health system? In other words, should we just be rethinking and using the currently available resources differently, or do we need to really think about radical disruption in the health system?
Absolutely. And if the health system, we will analyze countries who have performed well. They all coordinate across sector. They all coordinate with their partners. They were all community driven. And in those countries, like in Rwanda, there is no disruption of primary care. They all have built their COVID response successfully on a strong primary care system. And if it's not there, they have to build it because tomorrow there will be another one. The second thing you say, we should start now to think about all the developing countries starting little factories to respond to the need of the country, like we do here. We have started producing respirator locally. We start producing PPE locally. We are going to make error, etc., but we will be ready for the next pandemic.
Other thoughts about this big picture question we're getting, Emmanuel, about do we need to really rethink, reboot?
I think if we look, Raj, at the experiences that come from SARS 2003, and we look at Ebola, there are a couple of lessons. If you invest in preparedness, those countries that were hit by SARS in 2003, particularly in Asia, that will pay off. Maybe 15 years later, but when the big meteorite hits, you are ready, and they were ready, and they have been able to really contain the damage. And so preparedness is one big thing.
And Emmanuel, just to not to cut you off, but just to your earlier point about community and trust, a big part of that preparedness has been those Asian countries where the population says, I understand what this is a risk, I'm going to wear a mask. You don't have to tell me twice, right?
Indeed. On my note, preparedness and communities are the 2 points that actually I wanted to make. Invest in preparedness, invest in communities. And as Agnes was saying, it's so much more difficult to invest in communities and in a response, during a response. You need to do it before. And I have a bit of hope in the fact that for Ebola, we had a lot of innovations that were actually put in place in West Africa that became reality. They were just embryos there and became reality in DRC. I hope we're going to do the same, and we'll be going through this, innovating and then growing for future epidemics, pandemics, realizing that this type of collective solidarity, is understanding that no one is safe until everybody is safe, is something that doesn't apply only to epidemics and pandemics, and we'll see more in the next decades. Is something that applies also to antimicrobial resistance. Is something that applies also to climate change. So what we do have now is an opportunity to really radically rethink our world and our health systems around preparedness. As Mark Dybul used to say, we should be talking about systems for health. So health systems and community systems, and all our systems for health. And working at the 2 levels, the community system and health systems. My understanding after years of working in this field is that we have invested a lot in health systems. The community systems have always been the forgotten child. Now this has to change, and this is the opportunity to really invest heavily in communities and in preparedness moving forward.
Mickey, what do you think about this? Emmanuel is saying a radical rethinking. Are you of the same mind?
Yeah, no, I think for sure, I completely agree that the opportunity this brings to refocus on health, but not. So the first shift I would suggest is the one that we talked about earlier, which is with the ministries of finance and leadership, that health is an investment and not an expenditure. And getting that recognition that, as you said, Raj, that we could have saved ourselves trillions of dollars if we'd made that investment, instead of finance ministers looking at health as just a sinkhole of expenditure. So that shift in mindset at the leadership level of health as an investment in the future is going to be one important shift.
Mickey, just quickly, is that more of a kind of a long-term versus short-term thinking change that's required, right? If you're a minister of finance and you're saying, I need to get revenue now, I need to find ways to improve my budget picture now, versus maybe saying, well, if I invest in healthcare, prevention, primary health, that might not pay off while I'm finance minister. It might be 3 finance ministers from now. Is that part of the challenge? Or do you not see it that way?
But as you said, I think our challenge is to present that there are some very quick wins that can be made, which will have, and then the examples that Agnes and Emmanuel are given of countries which have very quickly and quite rapidly, and the SARS experience in East Asia is a classic one, that these countries, South Korea after MERS just a few years ago, invested in putting some of these systems and now reaping those rewards just in a very few years, within the lifespan of a finance minister even. So I do think we need to, you're absolutely right, be smart about how we position this. It's not just as a lifetime investment, but as an immediate investment, which will have quick quick returns. And then, as I said, the other area, in addition to the focus on primary and getting down to the community and building that trust, I would add the other aspect, which is very exciting, and you alluded to one of them, is the use of mobile technology, the e-payments, of being in touch with community workers, even in the most peripheral areas. So these investments could accelerate the use of innovation and of technology to really, to get a system which we learn from the challenges we've had in the past, when we've invested heavily in large numbers of community workers and often not got those same returns just because of the challenges of managing such large programs. So I do think this is a chance to look at ranging from telemedicine that we're seeing in many African countries through to e-payments like in Sierra Leone now. Community workers are being paid through mobile money and managed remotely as well. So
we have
big opportunities.
We have an article in the Study of Care series about frontline healthcare workers that talks about the use of robots during this pandemic. And I believe Rwanda has been using robots. And of course, these are the kinds of things that maybe are the cutting edge or maybe just the example that isn't the usual use case. But nonetheless, it feels like this could be a moment when the urgency is so great, the need to move so quickly is so great that maybe you could actually get faster technology adoption. I'm curious what all of you think. Do you expect that we'll see more of a digital health system in the future, just in the next 12 to 18 months? Or do you think, Emmanuel, you're working in places like DRC, connectivity is an issue, electricity is an issue, or do you think this is kind of pie in the sky and not likely to happen in the countries we're mostly focused on?
Thanks, Raj, for these questions. I happen to be on the Financial Times Lancet Commission on Digital Health, and we just ran the IFRC last month a huge consultations around digital health in humanitarian settings, where this was really at the center. And I think there are a couple of messages that came out. Yes, digital health technologies have an enormous opportunity at this point in time, but they need to be, particularly if we think about difficult settings, they need to be simple, cheap, able to work offline, sustainable, and having somehow a way to remain. Otherwise, the risk is just having a pilotitis, an immense exponential growth of pilots that actually do not have mass. The other points that came out of the consultation that was very interesting for me to hear is there was almost unanimous agreement that technologies are 20%, people are 80%. While you do have technologies, you need to make sure that you do have the people that actually sustain and make the technologies happen. And what was being brought forward was the issue of contact tracing. There was a lot of hype at the beginning over the past several months about contact tracing, which are actually tracking apps. And yes, they are helpful. But the contact tracing is a human-to-human relationship that requires trust, the trust that Agnes recognized earlier. And technologies cannot eliminate that element of trust. So can simplify certain transactions, but health is a lot about trust. And we need to, while we move on technologies and we support that, we need not to be swayed too strongly in that direction, because the risk is that then we lose the human side. A vaccine is a good technology, can save lives, but if you don't build the demand, the acceptance in the communities, that vaccines will not be able to save people, because will not actually reach the arm of a child or an older person in a community.
Raj, can I say something? For the trust, remember this country. 25 years ago, it was totally upside down. 1 million people killed by the neighbors. And today, if you look at the Wellcome Trust survey of last year, Rwanda is the country with the highest trust in the health sector. And we have a so non-finished health sector. I have to tell you, how many respirators do we have, etc. But people trust. And because of that trust, when we stand and say we need masks, people have, even some of them never saw a mask up country. They will list you, ask question, and put the mask. And this is what makes the difference. And for vaccine, it is the same. And for robot, is the same. You can see that we have robot now. We are preparing. I was watching this morning a reportage on the opening of the airport, what is coming, with robots circulating and tell to people, wear a mask, you see. And also taking the temperature so that you decrease the contact. You can use technology to improve care surrounded with trust is good. There are some countries where there is this hub for contact tracing. People stood up and say, my liberty, I don't want you to follow where I'm going. If you do that in Rwanda, because people know that it will serve them, it's not because they are just following without thinking. They just say it's a very good way to decrease the burden, the human burden, and to improve the health of the population. Trust is a social determinant of health, of education, and of development that is totally neglected.
Yeah, it's interesting. We had a question come in about the private tech companies and how they can play a role in this. And when you think about how much they have grown given this pandemic, right? I mean, if there's any beneficiary, it's the biggest technology companies in the world. We're all on these video conferences, right? And you look at their stocks, they've rebounded and gone to all new highs. I think it's 15% of the world's stock markets are now, the value is just 5 companies, the biggest 5 technology companies in the world. And yet, when you talk about trust, a lot of the trust problem is the spread on a lot of technology platforms of misinformation, of conspiracy theories, of people telling you things that are opposite to what the health authorities are telling you. And so it seems in some ways technology could be the solution, but it's also part of our challenge today. And especially when it comes to this issue.
It's not the technology, Raj, that is the challenge. It's the law and the accountability framework. If you lie with using a technology or just lying like that on simple old radio, and you can get out with it, that's the problem of the law. If you lie using a technology and you are catched and you pay the price of the people you kill with this, that's the problem. So the problem is not the technology. The problem is the legal framework.
Yeah, and that's obviously something you in Rwanda know a lot about, thinking about radio and right the way people can spread lies and how damaging they can really be.
The genocide. Yeah.
Do others want to chime in on this question? We've had a follow-up to it, which is basically about how do we nurture this trust? We're all saying that's really important. But when you have a healthcare system in some countries that's broken, today we have an in-depth piece about Tanzania, the mixed messages that the government there is sending about the virus. How do we nurture trust in this environment?
If I can go, maybe I would just say we need to start from the very top. We have had leaders in the world, and I often look at the Prime Minister of New Zealand, Jacinda Ardern, who have been built the entire response to a pandemic in their own country on trust, on listening to people, and then responding to the questions and understanding what the fears were and trying to address all people. There are very few leaders that have spoken to children, adolescents, and it's absolutely critical to do so. And we are seeing now in how the epidemic in some countries is being spread by youngsters who are not actually adopting the norms. And then that is having massive effects on older population. And I think the ability to listen is the priority number one. It needs to be starting at the very top, and you have modeling that start at that level and then comes down through the levels of government, and then it should be present at the community level. That's where we have our volunteers out. Something that we have tried in DRC during the Ebola outbreak in North Kivu is the introduction of feedback mechanism. We have our volunteers entering the communities. They collect their fears, their doubts, and we analyze. We did that with the CDC, and we map what the main concerns are by location over time. And then we adapt the change. We change the approach based on the feedback that we have received. And then we go back and we see whether these concerns have actually decreased. This is a feedback loop that I think is absolutely critical and needs to go down at a community level to build that trust, to see that people are not only listen to, but the people who are listening are actually acting on that. It goes back to the point of accountability that Agnes made, and it comes from the service providers who need to be accountable to their clients, because I think they're not beneficiaries. These are clients that deserves services, that have a human right to help that needs to be fulfilled.
The other thing, Raj, is participation. You listen, you respond, you adapt your speech, make sure that you are understood, and also you make people participating to the response. And if you do that, they will know what is planned and they will follow you.
It's amazing how in this crisis, we have really seen the importance of behavioral science, right? I mean, it's something many people have spoken about in the global health field. But boy, if you look at the countries that are doing well, it really does come down to these kinds of basic things. If Manuel talking about a leader speaking to children, it might sound like a small thing, but the countries that have done that, and Bill Gates mentioned this recently as well in an interview, that because of the exponential nature of the virus, relatively small changes at the right moment have a very big difference in outcomes. Yeah. And you can see that across countries. The outcome differences are dramatic based on what seem like pretty basic, small social determinants, talking to people, giving them a chance to understand an issue. I think, Mickey, you wanted to get in on this question.
Yeah, and I want to complement what Agnes and Emmanuel said, but also point out that the way you build trust is also the way in which your system is set up and established. And so two systems in particular I want to draw attention to is, one is how you finance your health system. And so, if you have a fair financing system where, it's no payment at the point of care, where access and equity at the heart of your financing process, then I think, those societies have built a far more robust and resilient and highly more trustworthy system than those countries which rely on out-of-pocket, which have two-tiered or three-tiered systems for the rich and the poor, and so forth. So I think looking at how your systems have been set up and are being, and this is maybe an agenda moving forward, is to draw attention to your financing system, but also your HR system. So, we still continue to put higher value on urban-centered medical training for highly specialized elite medical professionals, as opposed to what most countries need, which are generalists and community-based and training and capacity in the communities. And those programs are out there, those innovative training programs are out there, but nearly always they are, not got the prestige of the medical school in the capital cities. So thinking about how we value and the messaging we give around some of these key systems also build that trust in a maybe more sustainable manner than for the more immediate behavioral types of things as well.
I can tell you that one day when we're able to travel again, I would recommend to all of you to get to the University of Global Health Equity in Rwanda, where Agnes is the co-founder and the vice chancellor, because it precisely tackles this question. It brings, university students who are, the best of the best, brilliant people, but says, hey, come out and live in a rural area and learn what it's like to do health for people in these communities. And it changes your perspective completely, right? And it addresses a lot of these social and status questions that you're bringing up. Agnes, please tell us more.
No, I just want to say that this was one of, when I was a minister, you educate doctors when even if they are born in a rural area, they don't want to go back there because they believe their life is finished. They're young, they want a pub, a cinema, their friends, and they don't want to go and work with the people that are the most in need, rural poor. So that's why we decided to put the university in the most remote district of Rwanda, and we have built a state-of-the-art university, but in the middle of the communities. And this is the best education we can give, because our students are capable to go and work whatever place in the world. We treat it's an international university, majority are Rwandan, but they can work with street young people, drug addict in US or in Papua New Guinea or with Aborigine or in Rwanda, etc., because we have educated them like that with those ethical principles of global health.
Do you think there are other issues like this related to status of healthcare workers? You know, in many countries, we talk about community healthcare workers not being paid, nurses, not being well paid. What do you think of the question of status of healthcare workers? As I said, in much of the world now, including where I live, you see signs, praising and thanking healthcare workers, but we're hearing examples from all of you about how, in many cases, even the basic compensation isn't there.
That's true. And I want to tell you that in Rwanda, we have 4 community health workers per village. We have around 15,000 village. The community health workers are elected by the village, but agree to be volunteers. However, they are awarded by performance of what they do. They treat, they diagnose, they transfer. This is this amount of money they will receive for service rendered. It's not a lot, but it is something because we don't have the money to do more. And when people, when I came in this country in 96, you know how much I was paid a month? $75 a month. Huh? And I was accepting that because everybody was paid like that. So when you are not happy is when there is an injustice, not when there is a call for solidarity. And our community health workers system is working well. They are not working for free because it's against service rendered, but they are not very well paid. But nobody is very well paid in this country. And the status of doctors from education in those cities where I went to school with some young people at that time who want to go there to make money. I remember the status, we don't want our students to pay because we want to take students who cannot pay. We don't want them to take a loan and spend 25 years to reimburse that because they will run after money, not after the people. So we just say, after your studies, you have to work in a place where you are useful for the vulnerable, whatever place you want in the world, but work for service. You keep your money. And for us, we mobilize the money for you to study.
Emmanuel, please.
Just linking back to your point of what will the Minister of Finance do next year, when the budget for next year will be discussed. You probably have lower revenues. You have ODA shrinking. What is the minister going to prioritize? And I think this is where we will see the challenge of this pandemic being confronted by decisions. And unless there are investments made on this community health workers, and there are trade-offs, but really investing on that expansion and on the strengthening the incentives, which may start from the stipend, but would also need to go with the health insurance, the hazard pay, the life insurance. Unless these are not put in place, there is a risk that this will remain empty words, and we will not be able to prepare for the future. So I think there is a real policy decision, financial decision that needs to be taken in the future, and maybe between respirators, adding respirators or a CT scan versus expanding your community health workforce, and decision will need to be made. My hope is that we will be able to make a very strong case for investments in expansion of community health level, showing that the return of that investment is very big, and putting protection at the core of our investment, the recognition at the core of their work, of their role in the society at the core of the investments.
And those trade-offs might just get much worse, Mickey. I mean, we've got a lot of developing countries that were told during the Addis Ababa forum on financing for the SDGs, hey, you need to kick in more of your domestic resources. Some have been doing it, many have not. And then you get to a situation like this, a prolonged recession. Countries that are the most vulnerable are probably going to see their tax revenues drop considerably. They're not going to have the money. That trade-off that Emmanuel talked about will get worse. You talk about the debt burden that many of these countries are facing. Of course, the G20 they're doing debt moratorium. They're suspending some debt payments, but this is a long-term fiscal challenge. It seems like probably the donor countries might need to step up in a much bigger way Otherwise, those trade-offs could be catastrophic.
No, you're absolutely right. And so we have to double down on this global solidarity message that, we're as strong as the weakest link, and that the investments in health systems in low income settings gives you good return, and both for the human rights perspective, but also in terms of just your own safety and security as well. But I do agree also that there is going to be a challenge within countries, because whilst Emmanuel is right that community health should be a priority, what we're seeing, unfortunately, though, is most of this is happening in the urban context to begin with. And it's there where the systems are falling apart most quickly. I mean, India, Pakistan are classic examples right now, South Africa as well, where it is predominantly in the large urban settings where the system has been shown, is full. People are just flocking to the hospitals, which are not taking patients. So I do think we also need to think about what an equitable and solid system in an urban context should look like, and what is the role of primary healthcare in an urban context as much as in these more traditional rural areas. So I do think there's an agenda there that we as a global community need to re-engage with in a more innovative and different manner than perhaps we've done before.
Yeah, this has been a great conversation. I'm amazed looking at the time that we only have a few minutes on yet. So let me ask you, please add, but we're going to make this the last comments. And we did get a number of great questions in, so I'll just give you a couple of the themes in case you want to pick up on any of this. We're getting questions about gender dimensions. Of course, 70% of frontline healthcare workers are women, but if you look at the leadership of global health, unfortunately, it is nowhere near as equitable as that. Quite the opposite. We've got some questions in about stigma, where you have frontline healthcare workers facing the stigma of maybe being infected with the virus. And then others talking about the broader kind of silo questions around the way our industry is set up, and whether there's opportunities to break down those silos in this moment. So look, we're not going to get to all of that, but in the final minutes we have, maybe just a closing thought from each of you on any topic you'd like to bring to the table. And yes, of course, we'll start with you.
I just want to say that we should stop to look to Minister of Finance. Could we look to the Parliament? Because the Minister of Finance proposed a financial law of the year, the budget. Who voted? The Parliament. So that's maybe the place we should push, because the Minister of Finance just applied the politics of the country. That's what I wanted to add, and I totally agree with the question, but I let my friends here to answer the others.
You're right. This is a political issue now. If this doesn't wake people up and move parliamentarians and others, what will, right? Yep. Emmanuel, what are your closing thoughts?
Difficult. I'll pick up on stigma. That's what we are seeing a lot, and that requires protection of frontline health workers, which starts with PPEs, but will potentially very soon be with the distribution of a vaccine that may become available. I'm happy to see that the COVAX facility that has been recently launched, that has a very good ambition of protecting 2 billion people by 2021, will start with frontline health workers, and the doses, the first 3% of the doses will go to frontline health workers. And then once again, I want to reiterate the needs to protect financially, and as importantly, the need to protect from the psychosocial mental stress that the many healthcare workers are experiencing now. That is a moral obligation for all of us, and that's what we owe to these frontline health workers, beside the clapping that we all have been doing.
Thank you so much, Emmanuel. Mickey, your final thoughts.
Yeah, maybe just to pick up this really critical issue of gender as well. And I suppose another argument that we should be strengthening and making more forcefully to Parliament and to Ministers of Finance is that health sector investments is also an economic and a very productive part of the economy, and an important, and in the West, it's been an important cause of the growth of economies has been the health sector. And in most countries, health work is one of the few should be one of the, and is should become one of the few well-paid and well-respected jobs that women should be predominant and have been predominating in. So investing in improving the terms and conditions, the salaries, the safety, and the training of health workers is creating employment for women largely, And that has all sorts of important secondary economic implications as well. So I do think we need to really rearm ourselves with those arguments as health, not as an expenditure, but as an investment, not just for health for the sake of health, and not just for health for security, but also as an economic imperative, particularly for women and gender.
Thank you for that. And these are great points. What I take away on this is just how much we know on these topics. I mentioned before how many leaders in global health expected a pandemic would hit us at some point. And I think similarly, leaders in global health have a lot of great ideas about exactly what is required when it comes to the healthcare workforce in the front line. And I hope now is that moment when we take a lot of the knowledge and learning that we have from prior crises, from good examples from countries who are doing it well, and we start to actually apply that, and we can build the movement that's required. So I just want to thank all of you immensely for these great contributions. I know if there were an audience here, we would all be applauding. So please join me wherever you are in the world in applauding these fantastic panelists. Thank you so much for being a part of this discussion. Thank you.
Thank you.
Thank you all.
And as we bid farewell to these panelists, I do want to remind all of you joining us that there are some poll questions that you'll see on the platform. Please do take a moment to answer those poll questions. We'll be looking at those results shortly. And I want to welcome to the conversation Anthony Gatow. I just want to say a big thanks again to everyone there and give everyone a moment to look at those poll questions. Anthony Gatow is the Director for Global Community Impact for Sub-Saharan Africa at Johnson & Johnson. It's a real pleasure to have you in the discussion today, Anthony. Thank you for being a part of it.
Thank you, Raj. Nice to see you again.
Yeah, nice to see you too. And I was pleased to read your contribution to the Duty of Care series. I read your piece. You did a Q&A with one of our reporters, and you were really zoning in on this issue of silos. And how do we break down the silos in global health, and thinking specifically about community health workers. Can you tell us a little bit more about what you meant by that and what that's all about?
Yeah, the problem, Raj, is that a lot of the healthcare system, especially the funded healthcare system in developing world, is really structured in silos. So it would be HIV, TB, malaria, maternal and child health, reproductive health, and so on. And therefore, any resources coming into the system sort of comes down through a silo of either HIV or TB or malaria. And at the end of the day, the health system needs to respond in, so if it's a community health system, it's one community health system that you have one community health worker that goes into this number of households, and they must look at the health of the people. But because they're funded to do HIV, you might find that they focus more on HIV programming, or they focus more on TB contact tracing or malaria. And what happens then is that you have some areas that are over-resourced because the vertical programs are focusing there. And you have other areas in the community health system that are under-resourced because they probably are not a priority area for investment. Now, what that does is then you have an imbalance in terms of how the community health or the primary healthcare system looks from one part of the country to the other. And my call out for this was that why don't we look at the primary healthcare systems and community health systems especially, and invest in it ubiquitously, right? So that if you have a community health system in village A, it looks exactly the same as village B. And I think in this pandemic situation, we've seen how important that would have been if we had that equitable kind of spread of resources.
It seems like this could be a wake-up call for that moment. I did an interview with Mark Dybel during the beginning of the pandemic, and he was describing how he thought maybe this was a chance to get the software platforms that are often provided to community healthcare workers, an app for HIV tracking, another app for some other disease area, because people are stuck in these vertical silos, that maybe this was a chance to break down those barriers and have everybody equipped with that smartphone, with connectivity, with a single kind of healthcare environment where you could track disease issues across areas with one individual patient. That was more patient-centric. Are you seeing, in your experience now in the region you work in, any progress on these issues of breaking down those silos, for example, when it comes to software or other kinds of training or other programs for CHWs?
Yes, we're starting to see that. So in Kenya, we did launch the community health units for UHC in an effort to try and address exactly that. Because as we were co-creating this community health worker platform, that is part of the problem that we realized, that sometimes you might find that one community health worker has 6 phones, each provided by a different program. And then you have another in a county nearby that has absolutely no phone. Because they are all provided from those parallel programming. So why don't we spread these 6 phones among 6 community health workers that need it, but have only one system that they are working on, that then each different vertical program is able to pick their data from and is able to train these community health workers what they need done to be able to ensure that then you're really strengthening the system to respond to all these healthcare needs. So the way we look at that is we need to bring everyone together, and it starts from the top. It really can't be fixed from the community health worker or the community health unit perspective. It must start at the national level, where the programming is being designed, where we are putting together how this is going to work. If then you look at community health as a tool to provide service across the programs, and everyone is buying into this one service, then you then start to break those silos right from the beginning. And our challenge was to try and bring everyone in one platform that then looks at one plan for the country, works together to achieve it. And in that way, you also harness the strengths of each different partner to be able to deliver on this.
And this is the new acronym. Global health is filled with acronyms. This is an exciting one because it's actually a palindrome. I was amazed to see it. CHU for UHC, right? This is the community health units for universal health coverage that you lead and are part of in Kenya. Tell us more about that new acronym, that new platform, and what it's for.
So the CHU for UHC platform speaks to exactly what I was saying just before this. It's really looking at this. The community health unit is a basic unit of provision of community health services at the lowest level, and usually composes of about either 10 to 20 community health workers that are working, reporting into a primary healthcare facility. And the reason why we thought that we need to have that as a basic unit of focus is that if you then strengthen a community health unit, then you strengthen the basic unit, and the community health workers under that then are properly supported. They have the right resources, they are formalized into the system, and are therefore working together to be able to improve the health of the households that they are supervising. And that usually covers about 5,000 people in Kenya. So the reason why we brought this together is to say, what if all we who are working in a county in Kenya, for example, or in Kenya, then focus on that unit and say, what is it that this unit has to do to improve? And what we do use is, for example, the community health worker assessment and improvement matrix that is championed by the Community Health Impact Coalition, is to assess what your current status is. Once you have that assessment done, you then put the requirements to improve it to where it needs to go. And then using that method, then you have a continuous process of improvement that then gets you to the ideal scenario where you want to be. But the main thing was to start that conversation of saying, hey, let's sit together. Let's look at this as a common challenge and work on it together. And one big success I would say that came out of this is that when COVID-19 hit in Kenya and the ministry looked to community health, the CHU for UHC platform partnership came together and actually developed a position paper that then was used as a basis for what exactly should community health workers, what role will they play in, and how will they be protected and trained in being able to provide COVID-19 services. And this was done together, and that's what we really want to achieve.
It's seeing the community healthcare workers in these units more as a system as opposed to a project, which is so often the way they're utilized. There's a pool of funding that's available for the next 3 years for a project in nutrition. Let's bring a bunch of CHWs together and train them on that and send them out. And instead you're saying, let's actually have a systemic approach where these are community healthcare workers who are trained and are patient-centric, and they can work in nutrition, sure, they can work in HIV, and when there's a pandemic, they can work on COVID. And that is a different way of thinking about this, and it's not the case in every country in the world. Another big challenge that came up in the last conversation, I just want to get your take on it, is basic compensation for healthcare workers, including CHWs. Why is this still such a big question? Why has this not been dealt with? What is your take on this issue of compensation for healthcare workers?
I believe and COVID-19 is actually showing us that what we've been championing so far, and everyone sort of is always fighting against the allocation of more resources to healthcare, is because they look at it as a healthcare issue. But what COVID-19 is showing us that actually lack of investing in healthcare systems, especially primary and community health systems, is actually an economic issue. I believe what Dr. Anyesa just said in the previous panel speaks to that. Because of the investment that Rwanda has made at the primary healthcare level, that is why they've had a much better response, because then you already have an existing system that works, and all you need to do is activate it for pandemic response. And secondly, you then have the community trusting it because it works. However, if the community doesn't trust the system because it doesn't work, and then you have a pandemic and you now come in and you're telling people you must listen to what we're saying, it causes a sort of a disparity in how this is going to happen. Some will trust and some will not. And that is part of what I feel the challenge is, because it's always looked at, we have a budget for health, and of course, every country has been committing, for example, to the Abuja Declaration to get to 15%. Most countries are not even there yet. But the challenge is that we do a top-down budgeting where we have the whole pie, then it is cut into certain pieces. And when the healthcare piece is given, then it's seen that a big chunk of that is going to human resources for health. So if you ask anyone, they say, yes, but a big chunk of our healthcare budget is going to human resources for health. But how much of that is actually addressing the need that is there? That is the key question. And so the best that a country would do is to really start from the bottom up and say, this is what we need for a primary healthcare system, for our health system to be able to be functional, and then fight for that budget, as opposed to just getting a piece of the pie. And I totally agree that I believe strongly it's a legislative thing, because if you leave it to the budget to be done by the time the law is already in place, then that's what's going to change. But if the law already dictates that this is what we need as a basic minimum for a health system, then we start moving towards the right direction.
Yeah, this is Anya's point about looking at parliaments, not just ministers of finance. We're running a little short on time, and I wanted to get to a couple of other points with you, if I can, Anthony. One is around this idea of a scorecard that I know you've put out there in the past. The idea that you could rate countries and the way that they operate in their health system one against the other. Tell us more about the scorecard idea.
So this idea, Raj, comes from our Center for Health Worker Innovation at J&J, where we're trying to look at that frontline health worker at the center of our solution. And when you look at a frontline health worker, it's really looking at issues to do with training and education, leadership and management, well-being and resilience, connection, integration into the system, and most importantly, respect and recognition. Now, for us to be able to see whether we are improving the lot of the frontline health worker to get to the next level where they're efficient and are happy in the system, we need to be able to be accountable for it. And the way I've seen it, and it works a lot in the private sector, is a scorecard that measures you against your commitments to where you want to be, and a publicly accessible one, where even your population is able to look and say, well, Kenya committed to do this, where are we versus that? Where are we in terms of status, and how are we progressing towards getting to a better place? And that will then make the frontline health workers work with you as the government, as partners, and everyone else to come together towards really ensuring that you're able to get to the next level in terms of having well-supported frontline health workers in the country.
Yeah, in a way, the worst kind of scorecard is what we're seeing today, where we all go online to check the latest statistics on how many COVID cases in each country, how many deaths, and you can score and see how countries are doing on things like mortality and spreading and testing. And that's kind of the worst kind. We want a scorecard at the way you're describing, Anthony, where we can see in advance what does a great health system look like and make sure we can all invest in that. Well, we've run out of time, but I want to ask you for kind of your last thoughts and call to action here. We've got global health leaders participating in this event from all over the world. What do you want to say to all of them as we wrap up today?
Thanks, Raj. I think what I would say to everyone is that we need to strike while the iron is hot. we need to act right now when everyone everywhere appreciates the role of frontline health workers. It is a dream for all of us who've been campaigning for this frontline health workers and for the Center of Health Worker Innovation. For us is to say, how do we take this momentum? How do we convert it into credible and trackable actions to make sure that we have frontline health workers supported, so that we have health systems that are ready to respond to such pandemics, but also in normal times? Because as I said earlier, it is not just a healthcare situation, it's an economic situation. If we strengthen them, then we wouldn't be too worried about how we are responding to any pandemic coming forward.
Well, thank you so much, Anthony Gutau, for your leadership on these issues. For the Center for Global Health, Health Workforce Innovation, which we've been tracking since it was started here at DevEx, and I think is playing a really important role in this space. And to J&J for their partnership, longstanding partnership with us at DevEx and with the global health community, and on today's event, helping to make it possible. Thank you very much for being a part of this discussion, Anthony. And please join me if you're at home, wherever you are in the world, giving him a round of applause as well, a well-deserved round of applause. And I'll ask my colleague, Amruta Biatnal, to please turn on her video as we continue to move forward in the session today. Amruta, how are you doing?
Thank you, Raj. I'm good. How are you?
Great to see you. Everyone, my colleague Amruta Biatnal is an associate editor at DevEx based in India. As you read all of the fantastic coverage our reporters and editors have been doing on COVID-19, on the pandemic, you're now looking at the woman who leads that coverage. And I want to welcome you to this discussion, Amruta, and hand over the baton to you as you're going to take us forward to the next panel. And I will be back at the end of that and look forward to hearing what comes out of this part of the session. Amruta.
Thank you, Raj. And welcome everyone to On the Frontlines. I'm sure, like me, you've learned a lot from the previous panel from the global health leaders, right from how health is an investment and what it takes to really build trust amongst communities. What we want to do in this next panel is to zoom in to some of those personal individual stories of healthcare workers. Healthcare workers are literally on the front lines of this COVID-19 crisis. Right now, they're grappling with not only the bigger questions of how to treat patients who have contracted the virus, but they're also grappling with how to take care of themselves and their own families. We'll get to those questions in just a bit, but before that, I'd like to introduce my fellow panelists. Mallika Raghavan is here with us today, and she's the Director of Country Engagement at Last Mile Health, which works to save lives in the world's most remote countries. We also have Farhan Yusuf with us, who's a health supply chain professional and youth advocate, currently based in Tanzania. We have with us Ngozi Opara, who's a specialized nurse and a specialized midwife, and currently she's the Assistant Director of Nursing Services at the National Hospital in Abuja, Nigeria. Also joining us is Dr. Khalid Abraham, who's a tropical health specialist and Deputy Head of Mission at MSF in Sudan. Welcome to you all. I would just like to dive right in and go to Mallika first. Mallika, you've worked with a lot of healthcare workers in a lot of low and middle income countries across the world. And we know that healthcare workers have always had limited resources at their disposal. What about the COVID-19 crisis makes these challenges for healthcare workers even more pronounced in this moment?
Thanks so much. So I think maybe two things to focus on are first that we can see first and foremost that COVID is affecting every country, but we know that those impacts are going to be most devastating in rural and remote communities. And those communities are often left behind because they have limited access to health services. And so in a public health emergency, we need everyday local health care. And we know that community health workers can provide that. We need a health system that is resilient, that's adaptive, and one that can surge in a crisis. In particular, during the Ebola outbreak in Liberia, we learned that nearly 1 out of 10 of Liberia's healthcare workers, they lost their lives to Ebola. And so we know that we can't lose any more of these essential health workers, and we know that that will leave the health system even more vulnerable. Furthermore, female health workers are disproportionately affected on the front line of a response. So globally, 70% of our health workforce is female. A majority of those are underpaid or unpaid. And recently we've learned that the poorest women subsidize healthcare with their unpaid work with the tune of over $1 trillion. That's larger than the economies of about 150 countries. And so we know that the economic toll of unpaid labor, the scarcity of resources, and particularly women's essential health needs, that means that they're less likely to have access to routine health services, to essential medicines, to vaccines, to maternal and reproductive health care. And so it's really essential as we're thinking about vulnerabilities caused by COVID that we're also thinking about both access to essential health services and considering women as front and center of our response.
Right, that's so important. And the fact that, gender plays such a big role, in a crisis like this is something that has resurfaced time and again. And I would like to take this opportunity to go to Ngozi. Ngozi, you're a registered midwife and nurse. How do you think this crisis has, surfaced these questions again of gender and female healthcare workers? And how are you tackling it at your own personal level right now?
Laudable. Are you hearing me? Can you hear me?
Yes, we can hear you.
Right. I'm sincerely happy to be part of this panel, and it is something that is important for nurses, midwives, not only in Africa, Nigeria, it is a global thing. But I will speak on the area of Africa, Nigeria for one. Health workers, as a nurse and a midwife, because I'm both, I'm a nurse and a midwife. Females are more in number. So there's no gender disparity when it comes to this being in this profession as a health worker. So we take the upper hand, we take decisions. We have males among us, but they are maybe, let me on my own approximate it like 3 to 4%, but women are more, therefore no disparity. We are well-trained nurses, midwives, that midwifery is done by females. It's not done by male. So nurses are females, midwives are females, and they are the people that now take care of the patients or the community healthcare services. It is the midwives. And these are why in my country, the Federal Ministry of Health has a package that they call midwife scheme. And this midwife scheme trickle down to the communities to be able to render healthcare to mothers and the general public, especially to prevent maternal mortality and infant mortality. So in this period, we are there. In this pandemic period, we are there. We take the upper hand, we take the lead, decision-making body. Yes, some of us are not, we have people that represent us in the Federal Ministry of Health. And so in every state, because what happened in the federal happens in the states. So it's like a trickle down. And decisions that comes from the federal trickles down to the state, and the state now act particularly according to what is obtainable or the event that is happening in their own place, in their own state, based on the provision they have. And decisions that any new invention, any new invention, or let me use the word ideas, is also shared and people move from the federal to the rural to update them, so that they can carry on healthcare from place to place, from moving, so that we will have reduction in mortality.
Right, that's really important. And what I'm hearing you say is that there are some issues that should have been tackled a few years ago. Some issues, sort of are structural issues and support that should have been given to healthcare workers long back. Coming back to the COVID-19 crisis, Dr. Khalid, if I can come to you next, I'm wondering what you think are some of the immediate needs that healthcare workers face right now, and what can be done, in the short term to help them do their job right now.
Thank you, Armota. Actually, from following up in Sudan and different areas in the globe and the countries, I found that, or many people see that the leadership is really essential, really to guide the overall national response and the groups, smaller groups response as well. So if we take any country, for example, I take Sudan as a small example. We're in a transitional period where there is a bit of a disconnection of a national guiding policy compared to how it was sometimes in different places. The national guide is a bit missing there, and it's reflecting in the leadership in the health system, in the official health system and the voluntary health system as well. This is leading to really fragmented responses, even though the country has issued certain directives from the global overall response. Yet leadership was a bit of a missing piece there, a big missing piece. That has reflected in a very serious issue. Like for us in MSF, we look at the patient's right and ethical issues. I think it showed up without a strong leadership in the COVID-19 response, and without having a very strong ethical grounds in the individual's training and capacity. They have the fear of confidence, the lack of confidence, and the fear of self-infection, the family infection. Then the result comes as less people having access to healthcare. So if I link it correctly, knowledge, confidence, skill, leadership, these elements, if they're missing, the price would be very high, a very low compliance with the medical ethics in the health care provision service, which is a serious issue. I have a very simple drawing. If you look at it, this is a patient, this is a healthcare provider, and this is a patient. The ethical issues should be around in the middle. So each one has a space for self-care and self-protection. When we have an emergency situation, usually it goes like that. Most healthcare providers put themselves in a risk, giving more room to serving the lives of the patients. When the healthcare provider have more fear, they push the ethical and the ground to save more of their life, and they put more of the patient's life is at risk. This is a very simple way to describe the current situation. If you look at the fear of the healthcare provider from encountering infection, it goes there. What does it affect? It smalls or lowers and diminishes the space for the health seekers, the patients, COVID and non-COVID as well. So it gives them very small room to save their lives. And it allows a false sense of protection that is given to the healthcare providers in a big way. And I think the leadership should really help to keep this, if you allow me to call it a dashboard or something like that, a virtual dashboard, in the middle. Each one should be safe and giving the patients the right to access healthcare services. So that's a simple way to describe it.
Right. Thank you so much, Khalid. And you bring up such an important point about leadership. And This crisis has shown us time and again how much it's important and how it affects everything, right from the access of drugs to, like you were saying, how people on the ground are actually dealing with their patients and making these key decisions. And that brings me to Tanzania, where Farhan is. And Farhan, would you like to tell us how healthcare workers are, dealing with the situation right now in Tanzania? We understand that, we've just done a story today on the muddled messaging around the COVID-19 crisis in Tanzania. So it can be important, and it's key how communication is so necessary at this point. And do you think that has made a difference in a country like yours?
Thank you so much, Amrita. So I think before I get to the question that you have asked me, whenever I see these discussions around frontline health workers, I feel like one of the first things that I think is important for us to discuss, especially being on the front line and me being a pharmacist, is that I tend to hear a lot about doctors, nurses, and community health workers, but it almost feels like pharmacists and those related to pharmacy are the forgotten element even within the community health workers. And especially for something like COVID-19, if you think about it, we talk about community health workers, but with the kind of symptoms that COVID-19 had, it's pretty obvious that within the communities, probably even before the healthcare facilities, where many of the patients probably ended up were the pharmacies or the drug shops, because it was a flu, it was a fever, and that's where usually people start. Pharmacies and drug shops are usually the entry point into the health system. But whenever we speak about frontline workers, I feel like as if pharmacists are sort of forgotten. So I felt like that's important to mention. And I think one reason also of that, and which brings sort of another angle to this whole discussion, is the fact that I feel the reason for that is because many pharmacists and these, pharmaceutical dispensers are on the private sector side. And whenever, again, we talk about our response, we tend to focus a lot on the public sector, and we almost forget that there's a whole private sector element. And that's where many of these pharmacists and pharmaceutical technicians and pharmaceutical dispensers are. So I think one thing for me that has come up as a result of COVID-19 is these differences, that when we talk of, sort of our responses to these things, we tend to focus a lot on the public sector, missing the private sector. And we also tend to focus on certain cadres within the health sector, within the frontliners, and almost tend to forget others. So I feel like that is something that we really need to bring forth and improve on. As far as the response, here is concerned, I think the healthcare workers really took the lead in terms of, spreading the message and sharing information and providing the right kind of guidance. And I think what also came through very strongly for us here is, again, associations. And I think that's something that we don't talk about. We talk about, again, a lot of responsibility as far as the government is concerned, but then there's a lot that can be done by frontline health workers when they come through their associations, through their networks. So for example, we have, pharmacy associations, not just in Tanzania, but in other countries as well, that got into manufacturing their own sanitizers when it was required. So there's really that kind of response as well, where frontline health workers sort of came together and took lead in case of if there was any feeling of any muddled messaging. I think healthcare workers did take that lead to fill that gap.
Right, that's really interesting, and you bring up an important point of associations and people taking the lead. Do you think that in some way is a combination of lack of leadership and people trying to do what they can, or is it something that is sort of inbuilt in systems that are sort of resilient in themselves and sort of take the lead in going out there and making things happen?
I think, Amrita, for me, my experience again has been that, in our lower income countries, health professionals have sort of gotten into the habit of taking that lead, because we are used to working in very resource constrained environments. We are used to always, and I'm sure that is the discussion that was there even in the previous panel, and I'm sure we'll speak about it here as well, issue of limited resources, issue of limited equipment. So really, I think health workers are almost, from the training at the university level, even remembering my experience, because I studied right here in Tanzania, you're prepared to work best with what you have and make the most of it and take the lead in certain scenarios. So definitely that is something that needs to be appreciated for the frontline health workers.
Right, yeah, and there's also something to be said about how healthcare workers really just come together and make sure that whatever messaging is being received is being communicated to people themselves. And that brings us to the idea of strengthening health systems as a whole. And in the last panel, we talked about why that's important. And if Malika, if I can come back to you on that question, what does it mean to really have strong health systems on the ground, and how do you think this affects the day-to-day life of healthcare workers who are dealing with this on a day-to-day basis?
Yeah, great question. So I think one theme we're hearing across from all the panelists is that frontline health workers they're often the entry point, whether that's in the pharmacy, whether that's at the community level, whether that's in the hospital. They're the trusted actors within the health system. And so I think when we talk about strengthening health systems, really tying that to ongoing investment into building a resilient health system. So we're lucky that we have community health volunteers or community health workers, or generally healthcare workers at the healthcare facility, who often will respond immediately during, we're seeing in COVID, but also in other crises and other emergencies. And so I think when we talk about the health system itself, it's about ongoing investment, but continuously. And so, urging our donors, urging our partners to invest in frontline health workers who can respond at any point to a crisis. I think we saw that during and right after the Ebola outbreak in Liberia, the government really prioritized and made it a political priority to ensure that following the Ebola outbreak, there was a trained, supervised, paid, deployed set of community health assistants that would serve all remote and rural communities in the country. And since the Ebola outbreak over the last few years, the country has made increased and consistent investment into ensuring that those supervised, trained, professionalized health workers are able to respond. And we're seeing now during COVID that they're being called upon in their communities to educate, to prevent, to detect, to respond to COVID. And I think it's really important when we're thinking about investments in the system, we think about what that's going to mean, not just during a crisis, but before and after. I think the other point I wanted to bring up, and Anthony had brought this up earlier, is around how to design an effective community health system. And he spoke about the CHW AIM tool, the Community Health Worker Assessment and Improvement Matrix. And this is something being led with the Community Health Impact Coalition, USAID, UNICEF, and many others. And it's an effective tool to be able to do program planning, program assessment, continuous quality improvement. And so we're seeing that there are governments across the world, they're currently working overtime to respond to COVID. And so I think using tools like this to ensure that we're designing high quality community health systems can be really effective, and doing that as a coalition with partners, with the government, with donors is really essential.
That's really interesting. And the fact that even at that health worker level, the fact that different donors and different partners come together to make to strengthen these health systems, to make sure that the day-to-day operations are taken care of, is something that's probably ignored at a lot of times, but it's definitely an important point. Khalid, I would like to come to you to ask, how does this work in a country like Sudan, where resources are already strained, there are different sort of priorities that you need to take care of. And in the middle of this, when a pandemic hits, how does a healthcare worker decide what to prioritize on and how to sort of use the resources that they have at their disposal?
Well, actually, you hit in the real challenge that we're facing in our country. Sudan has been a country with limited resources throughout the past few decades, actually. And with the current situation where we're facing a shock to the health economy, and the whole population is really struggling to strive with very high level of malnutrition and different health priorities like different endemic diseases. You have a health system that is barely functioning and resilient as described, just moving on from one side to another. You have a pandemic that is hitting the country, but the numbers are not soaring high and not really scary. Still, so far, Sudan is about 10,000 plus the cumulative number of cases. So for a healthcare provider, the priority is for those malnourished cases, for malaria cases, there are different situations in front of them. And that is creating a very high level of conflict within the system, inside individuals and the system. And actually, that's where the leadership use what probably was missing, actually. You see limited resources throughout the time trains people how to adapt themselves individually and a system. When the pandemic as a new one comes in and the social media is scaring everyone, people focus on what they're used to focus on, depriving the current situation from the attention that it requires. But when fear overrides, then there is a situation of mismanagement and misjudgment. And that is where the ethical issue, I come back to the ethical issue again. It's a challenging situation. Currently, we are facing the second wave, and we are seeing the similar situation we've been in, but we're seeing also another situation where people are becoming desensitized, where the community is becoming less careful and more of a denial state or a bit of a careful, because their overwhelming needs let them see less of the risk of the way they're walking in the street. You see less and less people wearing masks. You see more risk at the health facility from people who are a bit denying the situation. It imposes additional challenges on the people in the health facilities. The frontliners are facing more challenge. They're seeing least resources. They're using least resources. They're missing the leadership. So their role is actually increasing, and they have to be in a better way to make the judgment. So they're really facing a big challenge, actually.
Thank you for that, Khalid. That's a really important insight into how decisions are being made and how people grapple with really limited resources. And Ngozi, if I could come to you with this question, you are a leader yourself. You are working at one of the biggest hospitals in Abuja. But so how do you tackle this? What do you tell the healthcare workers who are working with you, who are facing this on a day-to-day basis? How do you tell them to make these decisions, and what are the challenges that you think can be resolved, and how, in your experience?
The present situation, we always make sure that we highlight strict protection, because you cannot say you are serving and you now contract the disease. So all health workers, because of the training that have been given to us, making sure that we do all the protocols to avoid being contracted, so that we can stand in, because it's stressful to be able to manage these patients that come in. The speaker from Sudan said something, that the awareness, people are no more bothered about the disease, because our population is so high, and it's like is not what is going on in Europe. Therefore, there are like little doubts, unbelief going on. So for that, they come to the hospital without masks. So we give them masks to be able to attend to them, because that makes us, it exposes us. Now, we make sure that we monitor them. We take our records. We follow up the testing procedures, because the more you test, the more you'll be able to discover who and who is having this illness. And in our environment, and in my own area, the challenges are also manpower. The manpower is a very strong challenge, because nobody employed anybody. It is still those that are already managing the health sector in this country that is facing the COVID issue. Remember, they are having a difference in a hospital. There's an isolation center. The number of staff reduced to manage these patients. So other illnesses suffer. Other illnesses that patients come with, they don't receive adequate care, but we have made it mandatory that we have a specific number of people each time on duty. Generally, I'm not talking only of my hospital, but in the country and in our states, so that people will not be left to suffer because there's COVID. So the challenges are that there's lack of manpower. Again, the other thing is the the preparedness, seemingly poor preparedness, emergency preparedness, and the status. So in these seemingly poor conditions, the public health emergencies require quick identification and quick response, because when you identify the case, you'll be able to attend to the case promptly. But when there is no identification, probably for testing or lack of knowledge, you actually be exposing. And because our public health emergencies deal with either imagining or reimagining diseases, in some cases, we don't have a guideline or protocols. So not having a guideline or protocols has also caused a little gap in managing or taking care or following up this pandemic, the COVID issue. Therefore, we also, as a leader, advise that we have to have more training, review constantly, especially things that, especially our things in our shortfalls of the previous. For instance, when we had Ebola, so we told them, those that using Ebola as an example to refer to people taking care, remembering the past, not minding that no new thing was built or made for us to face this challenge presently. Another challenge is the ergonomic structure of our hospitals, environment, healthcare facilities, structures are not what it ought to be. It is not, because we have to have a place where if you come out, you can sight your patient from anywhere. You are standing or sitting. Be able to identify the machine that is calling for an emergency. So such structures are also lacking. It's a challenge. And as a leader, we keep on bringing it out from time to time to see how our managers, our leaders who are higher than us can listen and restructure this economic structure of the hospitals, so that when there's an outbreak, you don't need to start falling here and there and now making things not happen the way it ought to happen. And again, I will say something about exposing health workers deficit. I will still talk about rural area. Our rural area is important because it is from there the patients or the people who are sick they come out from to meet you that is in the urban. So if we don't have facilities that is really of a little bit standard to manage primary care before tertiary, it's always a case problem for the health workers that are there getting exposed to COVID or any epidemic. And more and more that I will say because of my time too.
No, thank you so much for that insight. And you bring up a really important point about, workers in rural areas and, how they have been able to serve the people. And that brings me to my next question of, how are we able to access technology in this crisis and really empower our healthcare workers to use this technology and to make sure that, their services don't fail, but they're able to access whatever they need at this time, especially given that we need to practice social distancing, the fact that not too many people are, able to travel. So if I could just come to Malika for a second and see, how different people from different countries have been dealing with this. And then maybe we could go around the panel and, if anyone wants to respond to that, we should definitely do that.
Yeah, I think it's an important question, and I know that for community health workers specifically, so much of the conversation has been on how do we quickly enable our community health workers to access key information and learning at their fingertips. And so, especially with COVID, we're finding that evidence is changing weekly. We're finding that we're learning about new protocols for community health workers. In particular, we've had to adjust a lot of the protocols in terms of the way that they might diagnose or treat malaria or diarrhea or pneumonia, because they no longer can touch the patient. They need to keep distance from the household. They need to be working with the caregiver. And so I think digital technology plays such an essential role because so many of these different decision-making protocols, training curricula, digital content and multimedia can now be uploaded onto phones that community health workers have, so that when their supervisor might not be nearby, or when they need to re-engage or look at, a protocol on COVID-19, they're able to do that on their phone, sometimes without ongoing supervisory support. And so I think digital tools play such an essential role, both in, I think, providing that needed training at the point of care, but also reinforcing key messages, also engaging the community around different content and health education. And as we continue to learn more about COVID, we can quickly adapt those materials and we can ensure that community health workers have that up to date. And so I think it's really essential, particularly in remote and rural communities where often, traveling to a health facility can take up to 7, 10, 12, 15 hours. And so really bringing the information to the community health worker in the community and equipping them to be able to provide that care at the community level is so important, when often we see some of the system and infrastructure and operational barriers that break down, particularly during a pandemic.
That's a really good point. And yeah, Farhan, please go on.
Thank you so much for that, Amrita. And actually, digital skills was one thing that I had written down. I have to talk about it on the call today. And great points, Malika, about having digital systems. I think what we need to consider, and I know earlier we were discussing about health system needs and how the health system needs to be prepared. I really think that two elements. One is having a digital infrastructure within our health system, and then ensuring that digital skills are a part of the even pre-service training for our healthcare workers. I think what COVID has also brought in front is the importance of digital, the importance of technology, and that it's not something that only a computer engineer needs to do or someone who's studying computers. But I think as we think so immediately right now, how do we upskill some of our healthcare workers to be able to use things like Zoom, for example, or to be able to use any other technological platform? But in the long term, how do we sort of institutionalize digital skills within our training and also in our health systems in general? In Tanzania, we had, text messages going out, creating awareness. We had WhatsApp services that had come up, as I'm sure with other countries as well. And I think healthcare workers found that quite a bit useful. I know there was a lot of trainings that were done using technology in country. So we had, different organizations coming up with different forms of trainings and upskilling for healthcare workers using technological platforms. And one more thing, Amruta, related to something that Malika said with how quickly things were changing around, protocols related to COVID-19. I think another discussion point is also how robust can our health systems be? Because currently, when you're talking about developing protocols or when you're talking about developing guidelines, the process tends to be in many countries so cumbersome and so bureaucratic and so long that, especially in light of COVID, by the time you take out one guideline, you realize that, so much has changed already. So how do we make our health systems robust enough to be able to support our healthcare workers in the right way when situations like these arise?
Yeah, that's a really good point. We'll go to Ngozi for a second and then come back to Dr. Khalid.
I think that it's good to improve the capacity of managers and to identify their own benefits of using research, because this has happened or this is happening now. What has happened before? What did we learn from there? So based on this technology that we are talking about, and it is good that the managers and those on the front line should be trained. They should have a training that they will fall back to their research. And research is not only what you are looking for, it's what you would have done, what you didn't do, the shortfalls, and you now pick it up there and now move it so that by the time everyone is knowledgeable, it will not be difficult. For instance, like the pharmacist just mentioned, all of this was not happening before. Zoom, talking, discussing, I can see you, they were not there. So it's this situation has brought in this new invention in technology. So at the end of this, I'm advising, I'm like saying that health workers should have an improvement, good training, then do a research, know your shortfalls. Next time, move it and trickle down this training. Let there be a trickle down effect, a retraining for every other person that is in the health sector from top to bottom, so that by the time any condition comes, people, then we also will like to, because some places in Africa don't have light, but there's a facility of solar. So solar is moving, solar light is now being used in some areas so that they can now have access to, because technology goes with light. It goes with light. Therefore, it is good that when we do that, people are trained. It will really breach in difficulties that we have encountered now. By the next step, we all will smile in a panel like this and say we have made an effort.
Right. Thank you so much for that, Ngozi. And if I could come to Dr. Khalid now with a slightly, second part of this question, because we brought up the point about the fact that how some places don't have electricity and people really need to build capacity. So Dr. Khalid, if we could just talk about how do you think this can be done while taking care of the local needs of certain places, and making sure that those local needs are really considered, and it's not just a copy paste of solutions from one place to another. Is that something that you have experienced?
Actually, yes. MSF works almost where no one else is working. And so we have experience working in remote areas with very limited resources and challenging working environment. Take an example of an IDP camp in a different place, in very remote area in Western Sudan, Darfur, or the refugees coming from South Sudan. So these people, they usually settle in a very far from residential areas where there is no power and so on. It's exactly what Ngozi was mentioning now. It's the use of renewable energy can be one of the solutions, but the word-to-word spread of news, and now we observe that everyone has a mobile phone. Usually people like smartphones because it helps them to communicate better when they're in remote areas. People have small set of generators where they can use it to get information and money, actually transactions across, to help themselves and other people as well. So the use of simple solutions can help the community. We can use that adaptable solution in a healthcare, providing and empower the healthcare with limited knowledge that they can help them and update their information. If you allow me to come back to a small point, technology is very useful if used correctly, but we see a concern of people really following the rumors and information that does not have concrete evidence, like use of certain medication to treat COVID-19. Certain elements, people say this help you to really improve and boost your immunity. Some of these materials, if you use them irrationally, it can be very harmful. I'm sure our friend Farhan has lots of experience in that. And yes, if we use that in the correct way, it's useful, but it can really be very tricky and very harmful if we do that. In MSF, we're trying to find a platform to use technology and get the correct message across and answer to people in the front line to empower them with the correct updated information. And I hope that it can be replicated in other places. It will really make people feel confident and use and do and act immediately with the correct messages, especially if you are in a remote place with limited resources and have no more senior person to ask, like different people in Sudan and different areas in the continent in Africa.
Thank you so much, Khalid. And you bring up a really important point about how different places have different needs, and the fact that we really need to consider what these places are and what the people are going through and what their specific needs and their specific capacities are. That brings me to the audience Q&A session, and one of our first questions is exactly about that. The question is that we know that in a lot of places access to clean water is really hard. So in these circumstances, how can healthcare workers who are on the front lines ensure that people are, practicing clean sanitation, that, they're accessing clean water? Is there something that has come up in your experience in the pandemic so far? If so, how can other places learn from it?
Yes, actually simplicity is the mother of life. If we try to complicate our lives, it becomes really complicated by ourselves. Filtering water through a clean cloth, boiling water, use simple chlorine that is becoming now very much available in different places. If not, use the sedimenting local materials. Have clean water, that is essential. So from there, we take it up. Use the water to clean your hands and move on and so on. So it's true. Many people have a lot of challenges just providing clean drinking water. But using simple available materials can help a lot. And using the appropriate materials can be even a better solution. Yes, in Sudan, we have a lot of these challenges. in different areas, different times throughout the year. If it's dry season, water is scarce. If it's rainy season, water is not hygienic. It's not good for drinking and consuming. So we teach people how to improve the drinking water for that. And I'm sure this can be replicated in different places in the world.
Right, that's very useful. Thank you. Ngozi, this next question might be for you. A lot of people are asking us, what are the specific needs that midwives are facing right now? And along with pregnant women, and how is it that frontline health workers, again, can help midwives, do their jobs well, be it through, using technology or counseling over the phone? What has been your experience, and how are the midwives that you know and work with dealing with this?
As the pandemic came up in my facility and in the country, the law came that pregnant mothers, expectant mothers must be attended to. That's a policy. Other people with minor illnesses and other regular illnesses were asked to stay put, stay at home for a while, except when it comes out as emergency. So mothers were attended to, the clinics. But initially, our gynecologists had a meeting and did not want to be registering new people. But after a while, 1 month, they start giving appointment to those already registered that are pregnant, attending to them all over, then opened up for registration. To social distance, to physical distancing, they had a particular number for each clinic day that they were registering according to the consultants, so that because we didn't build new structure, it was still the old structure. So we did that and were able to take care. Then emergencies, those that are pregnant in private hospitals, because some private hospitals were also afraid, they didn't want to take in patients, because there was a case somewhere in Lagos where a doctor operated on a patient and died, pregnant mother, and contracted Ebola and coronavirus and died. So doctors were skeptical, they were afraid. So doctors stopped attending to patients. But so such ones come to the tertiary hospital as emergencies. We receive them, protecting ourselves and them. We make sure those who are on book have a place, we attend to them. First of all, looking at the symptoms. You must look out for the symptoms. Are there things that can make you suspect? Are there things that will show from the patient that this can be, this cannot be? Some of them that had one problem like high temperature, we'll keep them in that room until it's confirmed that they are not. So definitely we attended to them. So mothers were taken care of. Deliveries were ongoing. Babies were taken care of. Then the facilities also isolated a particular place in case there's any pregnant that is positive with them. And even the neonatal unit had a place so that if such babies are born, they will be there. And nurses already stationed to manage them. So these were excellent things that I saw we did. We were but some of us initially were like, oh, it's overwhelming. But along the line, you must do and take care of these, because you don't know who next. So this trickled down and we managed pregnant women. Mothers came in, antenatal clinic was running, but in a very low scale, and we now increased as leads of movement from place to place, time and all that the government, the task force has put in place. Task force of COVID in Nigeria has put in place. So these things were managed in that manner. So we had no issues. Nobody, except maybe very difficult cases, definitely that did not die out of COVID or that had been mismanaged or have spent a lot of time before coming to higher facility.
Yeah, because you bring up a very important point of, building trust with communities, right? And how managing fears is so important in this time right now, and how, that really works with building trust over time and working with people and really ensuring them that the health workers are there with them and they can really hold their hand through the process. I wanted to sort of, broaden that point to a global level policy and maybe come to Malika for a second about how this idea of building trust can be built into policy, and how does that really affect health workers on the ground, and how can that help them really do their work better?
Yeah, I think to build trust at the policy level is also, I think it is about the engagement of community members, of frontline health workers, even in the design of policy. Often policy is designed and created and often even rolled out without kind of engagement across multiple levels of the health system, everything from the national level to subnational to community. And so I think when we're thinking about designing policies, particularly during an emergency, it's, I think, the time in which it's much easier to take shortcuts and not engage the actors that are going to be most impacted by those policies at the forefront. And so I think that's one piece. I think at the same token, we recognize that at a time like COVID, we need financing. We need support by different actors like technical partners or NGOs. So it's important when we're building that coalition of designing policy, whether it's during an emergency or long-term health system strengthening, that we're engaging all of those different actors and stakeholders together. I think in the same vein, it's also critical to have the role of civil society organizations or community-based organizations who often have a very strong connection to the community and can be strong advocates and are very participatory. And so I think kind of referencing back to the CHW AIM tool and the kind of like 10 components of how to design a strong community health program, through those 10 considerations, I think kind of alongside and complementing that should be, who are the people that should be part of that design? Everybody from patients to community level actors to donors to funders. I think that's how we see really successful policy being not just designed, but actually implemented and rolled out and often sustained.
Thank you for that, Malika. That's really important. And, the idea that looking at every person on sort of like the healthcare supply chain, if you will, and considering them into policy and how that can have real impact into the way that, health is really conducted and serviced and given to people. I realize that we're coming to the end of our time here. So if I could just go around the panel and ask each one of you to give one last call to action and what you want to see happening going forward. Maybe Farhan, we can start with you.
Thank you so much, Amruta. I guess my call to action, giving one is a bit difficult, but I guess what I would call for, I think number one is public-private partnership. I think that is very important so that the sectors can learn from each other and together come up with the right sort of solutions for when we are faced with challenges like this. I think we need advocacy at all levels to promote healthcare workers and their needs. So advocacy done at the global level, but then it needs to start at the community level and definitely engaging community-based organizations the way Malika mentioned. And lastly, I think let's have a health team approach so that even when you're talking of frontline healthcare workers, we are not focusing on one particular cadre and leaving another, but let's consider it to be a health team and look at all the different sort of specialities within that.
Thank you for that. Ngozi, can I come to next?
Yes, Yusuf, let me come to you again, because when you were talking about leaving pharmacists My last son is a pharmacist. So he's your brother. Now, in the health sector, we can't do without you. It doesn't matter, we are not calling pharmacists, physiotherapists, this and that. A health worker is a health worker. Anywhere, anytime, take it. Yes, and like you said, people are more so in the private sector than in the public sector. So let me leave that. I want to bring two things. One, I would love us to have this upskill and reskill in the health sector. Our partners are doing well. So our partner like the Smile Train, they are the ones that have made this, part of the people that have made this happen today. So it is good to have this training and retraining. And like Smile Train, they made it mandatory, it's compulsory that you do a step down. So when we learn, it is important that when we learn, we step down so that when we are not, the others can continue. The system will run over and over. There will be nothing like, stopping somewhere because that person is not there. The people that know it is not there. So it's good to step down every idea, every training, everything you have known about your health, the healthcare, so that it will run and trust. Therefore, on that note, I also advocate that, obtaining aids is important. We are not looking about financial aids. We are looking about this capacity building on training, equipment, because when you bring equipment, people will be trained. And when they train, they will handle it very well. It will last, it will serve the purpose for. Structural, economics, equipments, all these things are the things that we are asking people who are partnering with the health sector that are in the private to do for the health, not leaving it only for the government, because it takes two to tango, right? So, and that's another thing. Another thing is because you know that when you're looking at funding, it takes a long process. It's bureaucratic, and it might be managed well, it might not be managed well. Therefore, that's why I will prefer not having that fund. Rather train me, train everybody around me, train the nation, train people in the health sector. They are good to go. They will now move care from place to place. And communication is important. Communication is very important, so that by the time you let the other person know, by the time not the other person know, you move it, that anywhere you are, you have an idea of what is ongoing. This is what I can say.
Yeah. Thank you so much, Ngozi. And Malika, if we can come to you for a last round of your call to action, please.
Sure, I'll keep it short. But I think, like many of my colleagues, I think like Farhan was saying, the investment and kind of the investment into community health teams is critical. And I think not just during COVID, but after, we need to be ensuring that we're creating resilient health teams that can prevent, detect, and respond to any emergency. And so I think a call to action is for donors, for funders, for partners, for all of us to continue to advocate and to recognize the critical role that frontline health workers are playing right now. I think, and following when COVID is hopefully no longer here in our countries, to make sure that we continue to invest in those workforces, to train, to supervise, to equip, to pay, to ensure that they have the skills and the supervision that they need so that they continue to be resilient.
Thank you so much, all of you, for your time. And here at DevEx, we'll continue to track these issues. We'll keep reporting on them. We'll come back to you for your insights. I would also like to thank Dr. Khalid, although it seems like he's dropped off and he's not with us anymore. Thanks so much for your time, and I'm sure everyone watching really enjoyed this and really took away lessons that they can implement in their own work. I would like to now pass it on to Raj Kumar, our editor-in-chief, for the next session. Thank you so much, Raj, for having us on this session, and all the best for the next one.
Yeah, thank you, Amrita. That was a great discussion. You're right. I think people following along got a lot out of it. I certainly did. Really interesting conversation. And we're at a point now in the discussion where we want to bring in other voices you sometimes don't hear in these kinds of sessions. And really, that's what Duty of Care is all about, the content series I mentioned earlier in the day. First of all, if you haven't had a chance, check out Duty of Care. There's a lot of really fantastic content that colleagues like Amrita and others have put out there, and a lot of content from our community, opinion articles and other things. But one thing I really want to draw your attention to right now are voices from people who are on the front lines. That's the whole point of today's session. And so I'd like to ask the producers to queue up a video. We have a message from Jafari Lutavi, who is a midwife at the Muhimbili National Hospital and is with the Tanzania Midwives Association and the International Confederation of Midwives. And we just want to hear at this point from her to get a take from her perspective. And then we're going to come back to some more poll results, and we're going to come back to another video, and then we've got some more exciting information for all of you. So stay tuned, and let's hear from Jafari now, please.
My name is Jafari Utavi. I'm a midwife. I work with Muhimbili National Hospital. During COVID-19, we have faced a lot of challenges as a frontliner because we are directly taking care of these patients. When we rest with them, we have been treating them as a normal patient, but we have been taking care of ourselves by using the available PPEs, and we trying much at least to separate them and put them in a place whereby they'll be more comfortable and more secured, and even to protect others, because as we know, the pregnant mother are always at risk in getting further more infection because the immunity is low. My message to a global community is we have to take care of ourselves. If you take care of yourself, it means that you take care of others. So make sure that you're not putting yourself at risk in getting infection. Be safe, stay at home, and protect yourself.
My thanks to Jafari for that message. I think he has an important message because often in these discussions, we're thinking about COVID itself, but of course, women who are pregnant, who need prenatal care, who need to give birth in a quality healthcare facility, COVID has really upended a lot of plans of pregnant women, and it's created fear. And I think midwives like Jafari are doing a really important job in reminding all of us that we all have a role to play in this. So it's great to hear his message. During the course of this conversation today, there have been some polls. You've seen them on the side of your screen. Many of you have participated in that. And I just want to tell you a little bit about what we've found in these polls. There's some interesting numbers. So first of all, we were asking what's the most important thing healthcare workers need? And the vast majority, 65%, said really it's about the entire healthcare system being strengthened. A much smaller percentage talked about compensation and training, fair compensation training opportunities, and about a quarter of access to adequate equipment and medical supplies. But really, it's clear that the systemic issues are coming through. I'll say more about that in a moment. It's all about the whole healthcare system, not just about the healthcare workers themselves. We asked another interesting poll question about what's the best way to address the shortage of healthcare workers. Right now, WHO says it's 18 million is the shortage. It's massive. And here a majority said it's by upskilling and reskilling staff at different levels. In other words, by taking measures to avoid brain drain was a relatively small number, 16%. By training more healthcare personnel, 30%. That takes a long time. But a majority say, hey, let's upskill and reskill staff at different levels. That's a much shorter term potential solution. Interesting to hear the take from obviously a lot of experts in the field who are joining this call today. And then finally, what should global health leaders pay more attention to? This is interesting. A majority say advocate for more investments, again, in health systems. You might have thought they would have just focused on health workers. We have a quarter who say ensure healthcare workers are fairly compensated. 2 in 10 say advocate for more political will to increase health budgets. But a majority are saying advocate for more investments in health systems. And again, I think the systems question here is really critical, maybe not totally expected if you think about an event like this focused on frontline healthcare workers. So we'll come back to that systems question in just a moment. But I want to just say before we do that, that we've got another message, and this is our last message today. It's from a nurse, Matias Videla, and he's a nurse in Salta, Argentina. And let's hear what Matias has to say.
Buenas, ¿cómo están? Mi nombre es Matías Videla, soy asesor de salud de la provincia de Salta. Estaba acostumbrado al contacto directo con las socias día a día. Ahora lo realizamos desde casa. El compromiso con ellas sigue siendo el mismo, creando un sistema de atención virtual donde evacuamos sus dudas a través de llamadas telefónicas. También realizamos capacitaciones brindando información validada, campañas de diferentes temas como por ejemplo el ciclo menstrual. Ser parte de esta gran lucha contra el COVID-19 se siente muy gratificante, con una responsabilidad enorme. Les quiero dejar un mensaje a todos y todas a nivel global. Es motivar a seguir cuidándonos unos a otros siguiendo las medidas de prevención de la Organización Mundial de la Salud, ya que todos necesitamos poner nuestro granito de arena para salir de esta situación lo antes posible.
Well, when we're ill, we're used to listening to nurses. Hopefully we will all listen to this nurse. Matthias, thank you for that message. And it makes me think about one of the takeaways I'm getting from the day so far, and we're not over yet, but that's really about the importance of health systems. You know, health systems are a hard thing to understand. You don't really feel or touch the system, right? It's quite abstract. And I think most patients, most citizens, they know about their touch point. They know about their doctor or their nurse or their midwife. They know about their community healthcare worker, their clinic, their pharmacy, as Farhan mentioned in the last session. But do they know about the system? Well, I think one thing this pandemic is doing is it's showing the system to all of us, right? Average citizens are really starting to see the systemic nature of how healthcare works. They're thinking about things like, well, if I get ill, can I get a test? What kinds of diagnostics are there? What about tracing that contact to know if other people in my family or friends or colleagues might have picked up the virus? They're thinking about more broadly, if I get seriously ill, is there a supply chain for medicines or in the future vaccines? Can I get to a healthcare facility that will have respirators or oxygen? So we're starting, I think, to see what a system actually looks like. And when it doesn't work, why systemic problems are so hard, why you can't just solve it with some one-off intervention. And I think the experts who have joined the session today, and I again thank all of you who are from all over the world being part of this, you know this well, that there is no one simple solution. Well, we're just going to pay people more or we're just going to hire more. This is a systemic issue and it's going to require a different mindset. So one of the key takeaways for me, and I think the poll results emphasize that, is that these systems really matter. And I know Gitinji Gitahi is a doctor and the head of AMREF worldwide. I quote him in my book. He's constantly said that, you know, we don't do UHC because we're rich. We do UHC because we're poor. I think that very same sentiment applies to these health systems. It is cheaper, it is more effective to invest in the system than to try to put on a short-term solution when there's a crisis. And I think that's come out very much in today's session. I think key issues of equity have come out as well today. This idea that healthcare workers face stigma that needs to be pushed back on, that they face pay inequities, that there should be real and basic compensation for them, that they face challenges around training and tools, and that in particular, a very high percentage of the frontline healthcare workforce are women, and yet a very low percentage of healthcare leaders are women. And so you see maybe a healthcare system that isn't designed for the very workforce that we have, and that we need to take that more into account and do a lot of what I think we've tried to do today, and that's listen. to those frontline healthcare workers. Last takeaway for me is, we've talked about money a lot today. It's come up many times, and financing is a key issue. If you were to look at the richest countries in the world, and of course, many of them are facing huge challenges with this pandemic, they spend on average something like several thousand US dollars per year per citizen to provide healthcare. In much of the low-income countries of the world, low and even up to middle-income countries, the annual spending per citizen might be $50 to $250. So we're talking about an order of magnitude less. We're not going to bridge that gap entirely just by moving funds around within a government. That might be a part of the solution, but it's clear as we've listened to the experts talk today that we need to start thinking bigger about financing, that we need to set some floor for primary health care, and that there needs to be a bigger commitment from the world to ensure no one falls below whatever that floor might be. I think that's a big takeaway as well for me listening to this conversation, that if we care about systems, we have to care about financing. Dr. Paul Farmer has a phrase he often uses, the idea of socialization of scarcity, that we get used to, maybe in the global health field, we get used to the idea that there's a scarcity of funding. And if we get used to that, we might not advocate for more. And this is a moment when governments around the world are standing up huge multi-trillion-dollar initiatives around fiscal stimulus for their own wealthy economies. This is the moment to say, wait a second, we need to also be investing in the global health, primary health systems for every person on this earth. It's a unique opportunity to do that when we face a pandemic that's had such tragic results for so many people. So I really want to thank everyone who's been part of the session today so far. I've learned a lot. I hope all of you have as well. And it's been a real honor to get to listen to people who are on the front lines of this. I want to thank our partners. This kind of an event and all the content you see in the Duty of Care series, it just can't happen without a number of partners who bring their expertise and their commitment to the table. So I want to thank J&J. I want to thank Smile Train, and I want to thank MSD for Mothers for being a part of this session today. We are shifting gears now to a virtual roundtable that's going to focus on a key issue that came up a little bit in the last session around the role of the private sector, and specifically thinking about the role of the private sector when it comes to mothers and maternal mortality. And that's something we're doing in partnership with our colleagues at MSD for Mothers, which is one of the world's leading organizations on these issues. And I will soon be handing the baton over to my colleague, Alexander Cabaret, who is the Director of Partnerships here at DevEx. He's going to be leading that virtual roundtable. You are in the right place. Stay where you are, but you do get a 10-minute break. So I know we're people all over the world in different time zones. Get up, stretch your legs. If you need to get something to eat quickly, this is a good time to do that. And come back, because in just 10 minutes, we will be beginning the next session. And it's going to be dynamic, and you're going to learn a lot as you have all day today. So again, my thanks to all of you for being a part of it. And I look forward to hearing Alex and the other colleagues on this next session. Thank you.
Hello, everyone. Very pleased to restart this conversation today, a conversation on the front lines, and very pleased to welcome you all to this DevEx Roundtable that we are happily co-hosting with our partners at MSD for Mothers. This conversation is part of our Maternity Matters partnership that we have with MSD for Mothers, and part of the Funding the Future series that's exploring how international donor funding is leveraging private sector engagement in reproductive, maternal, and child health. So before we start the session today and invite all of our panelists, you'll see we have about not less than 9 speakers for this session. We'll hear from lots of different people and many of the donor organizations that are involved in funding global health worldwide. I'd like to share a few takeaways from the previous sessions and really thank all the global experts, health workers, and DevEx colleagues who worked in preparing these sessions. For me, there was really 2 main key takeaways from the previous sessions that we can bring into this conversation. One is funding, really the lack of capacity and funding to enable health workers deliver quality of care for all. And the second point really is communication. So Ngozi said in the last point, communication is very important, and that is valid for the communication between the different stakeholders active in global health, in delivering local solutions for health, including international organizations, the private sector, and civil society organizations and citizens. So to close our day on the front lines, we have gathered a group of participants to this roundtable conversation, which hopefully can serve as an important milestone to help bridge the funding and capacity gaps that have been highlighted in the previous panels that we heard from today. So for the audience that's following up online, you can join the conversation, ask questions today via the chat box on the platform, or directly on Twitter using hashtag #OnTheFrontlines and hashtag DevExEvent. So to go back on the session specifically, we'll explore how improved data visibility and the sharing of best practices can be powerful drivers to further engage the private sector and really strengthen health systems and engage as many stakeholders as possible to deliver on the sustainable development goals, even during this COVID crisis. Just a few notes on statistics around funding and the challenges that we face in maternal and child health. We're looking at a review of reproductive, maternal, newborn, and child health funding published in The Lancet in the late 2018. Estimates between $10 billion and $13 billion was spent on average by donor agencies worldwide between 1996 and 2016. Yet we know that this is not enough. And according to the World Bank, and we've heard representatives from the World Bank earlier today, according to the World Bank, there is a $30 billion annual gap in funding for reproductive, maternal, newborn child health. And COVID has meant that policymakers are facing an unprecedented challenge in financing for health and addressing the social and economic impact of the pandemic. I was reading an interesting piece just before on DevEx from analysts from Health Policy Plus, which is a USAID-backed project, and saying that just between 4 countries, which are Indonesia, Pakistan, India, and Nigeria, if we're not adapting public policies and responding with localized solution, we'll see a 31% increase in maternal and child death in the coming year due to the pandemic. So it's really important to get this right and engage the right stakeholders in this response. So just to close on this introduction before I introduce our first speaker today, we want to encourage strategic engagement of the private sector capacity, especially local private sector, to help address the needs in maternal and child health in countries by tracking levels of current engagement and surfacing opportunities in these areas for the local private sector and for global private sector companies as well. So that's what we're trying to do here today. and we look at two areas we're specifically interested in. One is the data around financial partnerships and instruments that enable work between private sector and international donors. And the second one is investments engaging the local private sector. So without further delay, I'd like to introduce Marianne Etiebet, who's the Executive Director of MSD for Mothers, which is a $500 million initiative that help ending maternal mortality. So Marianne, welcome to the session and to the event today. I'd like to start with a quick question for you. Why is your organization, why is MSD for Mothers so interested in this conversation? And why is now a good moment to engage in this group discussion? The floor is yours.
Well, thank you so much. Thank you so much for the question, Alex, and thank you for all of the other panelists on this roundtable. You know, to answer your question really succinctly, we know that depending on the country and the region in the country, between 40 to 60 women and adolescents in low and middle income countries access critical family planning and maternity care services from local private providers. You know, whether these are local midwives in the community, local community pharmacists, local physicians, and during the COVID epidemic, that doesn't necessarily change. These local private providers are still, you know, either they're trusted or primary sources of receiving healthcare. You know, you've shared, and I see Monique is, you know, also on the panel, the alarm bells the community has been sounding about how the impact of COVID on the ability for women and communities to access essential health services. That is driven by both a lack of supply as well as challenges in demand for services because people are scared, you know, to seek services. And it's become increasingly apparent from, you know, my belief that local private providers can play a really critical role in the moment today where we're all experiencing the COVID pandemic of helping to augment government responses, both in terms of augmenting capacity to deliver services, but also augmenting the ability of government to communicate and reach out to women and communities and provide the information they need in order to safely access services. And so it's a really important conversation to have right now to understand the role of local private providers, understand the extent, you know, of what they're doing, how they're doing, what they're doing, how well they're doing, what they're doing. And we shouldn't have to be recreating the wheel in the midst of an epidemic, of a pandemic. We hopefully would have had this data at our fingertips, you know, understanding these networks of providers. So when there's an emergency, we can activate the on switch and, you know, activate their support. And so what, you know, we're really hoping we can come out of this roundtable with is, you know, figuring out some best practices around sharing data about what we are already doing in terms of collaborating and working with local private providers so that when we, you know, when we need to activate that on switch, we can do so in a just-in-time manner. And also we can learn from what we're doing. You know, we can learn what works, what doesn't work, where there are obstacles, you know, to advance effective and impactful collaborations. And I do think that all of this starts with, you know, understanding what's going on, sharing data, sharing experiences, and sharing the data in a way that's actionable for all of the parties involved. Thank you.
All right, thanks, Marianne. Yeah, I believe that's a very important point, and I'd like to ask you to also share a few insights about a project you've been working on with Aderanke Saba, who's part of the panel, and we'll have a quick interview with Aderonke now, who's joining us from Kaduna in Nigeria, a city that's north of Abuja. And yeah, just a few words of intro for Aderonke and the work you're doing with together.
Great. Thank you, Alex, and welcome, Aderonke. So, as you mentioned, one of the partnerships that MSD for Mothers is involved is a partnership co-funded with the Gates Foundation, where we are supporting the capacity building of local community pharmacists and patent and proprietary medicine vendors. We know that they are an important source of family planning services and products in many communities. And the work that we've been doing, with these networks, including collecting digitized data on the services that they provide, is an example of how that data can be used to inform government responses in a COVID pandemic, understanding who needs what where, and what services, what services you need to help facilitate in order to meet the needs of women and communities. So great to see you, Aderonke.
Thank you very much.
Yeah, thank you so much for joining us, Aderonke, and thanks, Marin, for this short introduction of the project. Aderonke, you're a community pharmacist providing much needed medicines to people in your community. And I was wondering, as a private sector provider, what role do you play in your community health system, and especially through this project that you've been working on in the past months and years?
Okay, thank you very much, Alex. Beyond providing the much needed medicines needed by the community, we also offer primary healthcare services, one of which the family planning is part of, which is pretty much the main goal of the Integrate E project, which we're part of. Yes, the Integrate E project is focused on expanding access to quality family planning services. And within this project, one of the things that we do is that we go out into the communities and we create awareness. We create awareness. The contraceptive prevalence rate in Nigeria at the moment is at about 17%, while in Kaduna, where I currently practice, is about 14.9%, which is below the target, the national goal for 2020, and that's in Nigeria, which is set at about 27%. So you can see that the role of awareness advocacy cannot be overemphasized. So one of the things that we do is we go out into the community, create awareness, provide a lot of information and education. You will be shocked to find out that there are a lot of people that are aware of family planning services, but because of the wrong information that they have had over the years, they've developed a sort of apathy towards family planning services. So another thing that we do is that we provide information, give them the right education, tell them what family planning is and what it is not, what family planning does and what it does not do. And when we've, gotten them to that point where they now see family planning in a new light, we guide them on method choice, provide the service to them. And eventually we also, beyond all these services that we do, we also make sure that we document that these services are well documented.
Thanks, Aderonke. And I was wondering how you're partnering with the public authorities locally in your region. I understand you work a lot with the local communities, and how is the articulation of your work with the public authorities, local authorities?
Okay. The Nigeria is a middle-income country with a population of about approximately 200 million, 49.5% of which are females. And a large percentage of that, they are women of reproductive age. And when you look at that amount and you try to compare it with the amount of the public health facilities you have in the country, you see that the public health facilities cannot possibly cater to the health needs of all the women. That's in terms of the family planning services. So pretty much what the private health sector does is we try to bridge that gap. And this project with this Integrate E project that is right now is with community pharmacists and the patent and proprietary medicine vendors. What Integrate E has done with this project is pretty much bringing family planning services home to the clients. You know, beyond those that are not aware, beyond those that are ignorant, there are people that are aware of this family planning services, but they are not able to access it. So, you know, and those are people that you call, like, you have about 20%, you know, we call it the unmet need. So what this project has done, it has made this service available, accessible to all those people. You know, in Nigeria, you have pharmacies and PPMVs in pretty much every neighborhood and community. So you find out that these women are able to access the services. You know, there is no, you know, they don't have to deal with traveling long distances to the public health facilities. They also don't have to deal with the wait time. You know, you have to go to these facilities, and because of the amount of people they have to attend to, you find out that you're spending a lot of time to access these services. But with this project that has, you know, that is open to the community pharmacies and PPMVs, you'll find that people can access these services more easily. You know, you can easily walk into the pharmacy that, you know, on your street and access these family planning services in little to no time. Another thing that I think that this project has helped is it has also helped to identify underlying health issues in women. You know, in Nigeria, you will find out that the average person doesn't, well, the average person, let me put it this way, doesn't go for medical checkups. The only thing that takes people to the hospitals is when they are ill, when they have certain symptoms and all. So what this thing has done, because before you can offer a service to any client, there's some basic medical checks that you have to carry out. I had a client some months back. You know, she came into the pharmacy and she wanted to access the service, and carrying out these basic medical checks, we found out that her blood pressure was extremely high. You know, and she came into the pharmacy, no symptoms at all, fine, hale and healthy, but her blood pressure was really high. You know, and at that point in time, we had to refer her to a doctor for further evaluation, refer her to the public health facilities for further evaluation. If she had not come into the community pharmacy to access that service, she most likely would not have known that her blood pressure was that high, and except probably she would have except, you know, should have most likely gone into an emergency situation. Right. But, you know, that was able to, you know, curtail that event. Yes, I'll say that what the private health facility brings, you know, we are pretty much trying to bridge the gap, you know, in a way. Right. Also, you could say taking the burden off the public health facilities.
Mm-hmm. Thanks so much, Adoranke. And I think it's a very interesting story, and bring it to real life example is really important for the roundtable conversation that's following. And I like the fact that you brought this example around diagnostics, which is a very important one, especially in the COVID-19 era, even though it's on a different health issue, but it's definitely a place where the private sector can play an important role. So thanks so much for your contribution. Please stay with us in case we have questions for you later, Adoranke. And I'd like to briefly introduce our roundtable participants, as we have about 35 minutes to 40 minutes conversation ahead of us. And we have Susan, who's joining us from USAID. We have Bianca from the Global Fund, Monique from the Global Financing Facility, and Mar from the European Commission, Anshu from the World Health Organization, Annie from Grand Challenges Canada, and Desta is joining us from Kenya, and Amref Health Africa. So very pleased to welcome you all. And I'd like to start with a question directed to Bianca at the Global Fund, Bianca and Susan really, but I'd like to start with you, Bianca, as you've been with the Global Fund for 7 years now, working in the private sector partnerships team. So you've been with the Global Fund for quite a long time. It's one of the successful organizations partnering with the private sector in global health. And it'd be great if you could start off by telling us more about how the Global Fund works with specifically with local private providers as of today, and how you're leveraging private sector capacity to implement your work. I think it might go well in line with what Adoranke was just explaining. So.
Sure. Thanks a lot, Alexandra. And Marianne, Adoranke, thanks a lot for kicking us off. And I think you made a really important point, both of you, which is the need to involve local private sector providers. And with that, meaning both the formal private sector, so the private health clinics and the private health facilities, but also the private sector. So including in some areas, drug centers, pharmacists, and others as well that may not be plugged into, let's say, the national health system in a very formal way. So there are different ways of how, especially local private sector, can get involved in program implementation. The most straightforward way, and I'm not sure how much everyone on the line and participants are aware of the Global Fund model, but the most straightforward way would be to be or to become a main implementer actually of a Global Fund supported program. So working with the Ministry of Health, working through the country coordinating mechanism. Sorry if I'm throwing out too many technical titles out there, but saying that we have seen that in several countries, it's not the norm yet, or it's not very often, but we've seen very successful examples of private hospitals, but also even local companies, for example, that have run a successful malaria prevention program for their employees and their communities, have actually scaled that up, working recipient of a Global Fund grant. So that's one very straightforward way. But in a much more general view, what we're also seeing is that the public-private mix in program implementation, and that actually starts, in the national disease strategies, and acknowledging the important role that local private sector has in many of the countries, mostly in Asia, but also in many different ways in Africa, sub-Saharan Africa too, and including that in the national disease strategies, but then also in the program implementation. So meaning that the public-private mix, and with all the challenges that brings, but also the opportunities, is absolutely key. And just to give you two examples, I can speak from the disease perspective, but as many of you will know, investing in health systems is absolutely key to the Global Fund model. And if we want to end the three main epidemics that we're focused on, TB, HIV, and malaria, but also, when you look at maternal health services, Marianne, to your point, and Adoranke as well, there's a lot that the public sector can learn from the private sector, and the integration again comes with other ways. So, for example, to speak about if we look at TB, if we look at a country like India, one of the TB high burden countries, where actually 2/3 of TB cases are notified through the private sector, or where, let's say, patients that have a chronic cough, as a first entry point, go to the private sector, both formal and informal. So it's absolutely key to, one, if you think of reporting, and I know we're coming back to that later in the discussion as well, integrating the private sector into national health information systems is super important, because then you get a sense of how many cases are we missing, where do we actually stand. Maybe we're not missing those cases, but they may get the wrong treatment because they're not plugged into the public treatment protocols. So that interplay is absolutely key. And for example, with India, if we look at the programs that the Global Fund has been supporting, and it's like a huge array of stakeholders there, working with the Ministry of Health in the leading role specifically, but this public-private mix, and also working with a non-government intermediary, has actually proven quite successful. And just to give one more example, and I don't want to go into too many details either, but where we've also seen local private sector, and that also means the global private sector with local branches or local entities actually making a difference or adding a lot of value, is when you look at challenging operating environments, so conflict zones, countries where national health systems are really extremely strained. Private providers, but then also, and that goes now beyond the health private sector, but also other companies in terms of warehouse management, supply chain management, actually can fill important roles there, especially when it comes to emergency responses and being part of it. So in closing, that close collaboration between public and private sector is absolutely key, and will even become more so across diseases and all health services.
Thanks, Bianca, for that. And yeah, it would be great to understand how you're also reporting on that and how private sector stakeholders can better understand where the opportunities are to help strengthen these partnerships. I'd like to go to Susan now, and I mentioned the USAID backed project in my introduction. Not necessarily on purpose, but it's great to have you here. And be great to learn more about the private sector engagement policy that USAID has put in place, and how do you measure that engagement with private stakeholders specifically?
Great, thanks so much for having me. I think many people know that we launched this private sector engagement policy in December 2018. And it really calls for a cultural and operational transformation within the agency. I am sure it's not surprising to anyone that we are quite a risk-averse agency, being part of the US government. And we believe that having a strong private sector will help us reach our goal of ending the need for foreign assistance. So, you know, many people have heard us talk about supporting countries along their journey to self-reliance. We believe that a robust private sector is essential for countries to achieve that. One of the reasons that the policy came about was that we didn't have a standard definition of what the private sector is or who it is. And I think that, you know, we use the term private sector, but it's not a monolithic kind of one thing. And so we're still having lots of discussions, even though we have a definition now. And it includes for-profit entities. They could be of any sector, financial institutions, investors, impact investors, business associations, businesses of any size, so private midwives, community pharmacies, PPMVs, everything up to a Merck, and any company in terms of US-based companies, South African-based companies, regional, kind of the whole gamut. But it's very focused on commercial. And I will say that that makes a lot of people in the health space uncomfortable. I would say, you know, even host country governments. There's a lot of people that think that the private sector is, you know, greedy, and so I think that the difference between health being a public good and the public sector providing all the health is kind of a mindset that we're trying to shift, right? Stewardship by the Ministry of Health is very important, but that doesn't mean that the public sector has to provide every single aspect of health. I think it also emphasizes that, you know, we have very close relationships with ministries of health, with NGOs, with academia, with civil society. This is not minimizing those relationships, but we have not strategically engaged the private sector in a systematic way where we're really bringing them in to tell us what they think and what we want to achieve. Just building on what people were saying before about the data, a secondary analysis of DHS data in 25 countries showed that 43% of caregivers for sick children go to the private sector as their first source of care. And we think that it's only the wealthy that go to the private sector, but in reality, the poor also go. And so, you know, we see in many of these countries that the out-of-pocket costs are very high, and it's usually the poor that is having most of that burden. So with this definition, then people say, well, where do NGOs fit in? Where do faith-based organizations fit in? And we know that in many countries, they provide the lion's share of health services. So in the policy, we talk about for-profit market-based approaches. And the idea is that we want to use the drivers' incentives of the markets to sustain these efforts rather than donor dollars. And so the idea is, how can we make the market be more efficient so that, you know, the market will continue way beyond USAID support is ever needed.
Yeah. So it's really about building these sustainable health market ecosystems, right?
Exactly.
And, I think I'd like to bring in, if you don't mind, I'd like to bring in Monique Fleder to the conversation, who's the practice manager to the Global Financing Facility, as We know you work closely with governments in setting up strategies, global health strategies, and would like to know how you're collaborating with your partner countries and what you're seeing and hearing from these countries when it comes to further integrating private local stakeholders in the health response.
Great, thank you so much for inviting me. Really great to see Marianne and so many other friends around the table here for this important discussion. And maybe just to start off by saying, for those of you that are not familiar, that GFF engages with countries to under country leadership, define what we call an investment case, a set of priorities of what needs to be financed in terms of the systems, the financing, the quality of care to deliver for women and children in country. And for us, the private sector piece is very much integrated. We were established during the Financing for Development conference in Ethiopia, and that private sector pillar from the beginning was very much at the heart of GFF. I'll talk specifically around the country approaches. And so mixed health systems is at the basis of how we work with governments around the investment cases. A large part of our support and financing in combination with the World Bank IDA financing is for the contracting of a comprehensive package of maternal and child health services that is delivered with very high quality. For that, we are really agnostic, whether it's public or private providers that deliver that. What's important is that we can ensure high quality of those services so that it has the intended impact. And we do that before COVID, and that continues now by supporting, really ensure a dialogue between public and private sector from the start and go jointly into these design and prioritization processes. And understanding each other's culture and language is really important, and we can help facilitate that. And then to translate that into concrete actions and proposals that can be implemented, and we provide technical assistance then for the implementation of that. Now, when COVID happened, I want to segue a little bit to how COVID impacts these approaches, and this comes very much to almost every GFF countries. We're in 36 countries now. We do the private sector, health sector assessments, oftentimes in collaboration with other partners, and it's incredibly difficult to get really good data to make your decisions on. And so when COVID happened, we invested a lot in ensuring that we could measure what was the impact of COVID on the availability and the access to essential services for women and children. And across the board, we see about a 20 to sometimes 40% reduction in access to primary care services. And so that secondary impact of COVID has the potential of having even a worse impact than the COVID pandemic itself. And so the role of the private sector, and I was really fascinated listening to Adaronke and her experience in Nigeria, the role in the private sector is really, really essential there. And I'll give a few examples. One of them is that we're really struggling with the confidence of health workers to go into work because they are not able to protect themselves and protect their families from contracting COVID. And so the local production of PPE and making PPE, the protective clothing for health workers, available is very important. And we're close to finalizing some investments deal in collaboration with the private sector arm of the World Bank to ensure that Africa has higher local production of this protective clothing. We're also seeing a lot of disruptions, and particularly also in Nigeria, but many other West African countries, in the availability of commodities and because of the global supply chain interruptions. And so the ability to reduce the dependency of African countries on those the supply of those commodities from India, for example, and the investment in local production of those commodities is another really important area. And then when we come to the hands-on delivery of frontline services, we're seeing, particularly, for example, for family planning, that the private sector plays a tremendously important role. We have to think of different strategies when women are reluctant to access government facilities. What are different ways that women still can have access to family planning commodities? And the private sector here plays a really important role. And then maybe a final point is around the quality of care, and a lot of investment needs to happen in really seeing our role and supporting the government to play more of a regulating role to ensure that whether people access services in the public or in the private sector, they can access services of high quality. And so that's really where I see also where the global community can help further support to technical assistance and providing resources to ensure that when women access services, whether it's in the public or private sector, they receive services with very high quality. Thank you.
Thanks, Monique, and great insights indeed. And I like your point about data, even though it's different types of data. But I'd like to bring in Martinez from the European Commission Development Cooperation Office. Now, as the European Commission is one of the largest global development donors out there. It has come with a ambitious plan to leverage private sector funding through the European External Investment Plan. And you're coming to the end of it, the end of the first cycle that was for 2017-2021. You're preparing for a second cycle from 2021 to 2027, as you've told us yesterday in the conversation. And looking at your side, it looks like you've achieved most of the goals you had set, which was providing over 4 billion euro of financial guarantees, and you've developed over 140 projects of blended finance projects. And so we'd like to know what challenges you have faced in communicating with the private sector in the early days of the new investment plan, and how you're planning to do better in the next phase. I would say, how you're planning to collect this data, how you're planning to get these impact anecdotes or data to even better engage the private sector in the next round.
Thank you very much, Alexander, for the nice introduction. I'm delighted to be part of this roundtable, and the reason is simple: global challenges that, like this dreadful pandemic, require collaborative approaches, and we certainly need to join forces and break the silos that sometimes separate governments from the private sector, the academia, and the civil society. I'm glad to share our perspective, our experience, and also I'm willing to learn from you all. You know that our approach in the EU is rooted in the European values and therefore guided by the purpose of achieving universal health coverage, UHC. On how important the private sector is for us, let me refer briefly to our current programs in this unusual 2020. The European Union and its member states acting together as a Team Europe are taking comprehensive action to tackle the destructive impact of COVID-19. Team Europe has mobilized almost 36 billion for emergency response and to address the health-related and the socio-economic consequences of the crisis, and we are partnering with businesses. Businesses are contributing in many ways. As Monique mentioned earlier, businesses are stepping up local production of medical and protective equipment in developing countries. And another example could be that they are offering services such as internet at a reduced cost or for free. In parallel to the Team Europe response, the EU is also being the driving force of the Access to COVID-19 Tools Accelerator, groundbreaking global collaboration to accelerate development, production, and equitable access to COVID-19 tests, treatments, and vaccines for all globally. So far, almost 16 billion euro have been mobilized in the form of loans, grants, warranties, and the private sector is being an essential part of this process for manufacturing and delivering these solutions, existing solutions or new solutions that will come. But as you said, there have been challenges, and we need to think of the post-pandemic landscape. So for us, certainly digital technologies and financial investments can help strengthen health systems and empower health workers to deliver quality care. As you rightly mentioned, Alexander, in 2020, we are finishing our financing cycle during which we have supported NGOs, the Global Fund, UNFPA, and the next long-term EU budget for the period 2021-2027, known as the Multi-Annual Financial Framework, MFF, will open new opportunities. The Commission has proposed a budget of around 130 billion for external action in the next MFF. And it's important to note that by virtue of the European Consensus on Development, there are several spending targets. For example, at least 20% of the EU ODA should go to human development and social protection. This includes, of course, maternal and child health. In the current MFF and in the future MFF, the external investment plan that you also mentioned, the EIP, is our flagship initiative to partner with the private sector. The financial arm of the EIP, the European Fund for Sustainable Development, launched recently, only in 2017, has already committed 4.5 billion and unlock 47 billion. Under the EIP, currently there is one health partnership. It's the African Health Diagnostics Platform, which is being rolled out in several countries in sub-Saharan Africa. This is a partnership between the European Commission, the European Investment Bank, and the Bill and Melinda Gates Foundation. It pays attention to laboratory and diagnostic services for primary care infectious diseases, but also for non-communicable diseases, and based on the public health priorities as defined by partner countries. To conclude, we believe that the involvement of the private sector is indispensable, and we have to reconcile public and private approaches because both are necessary. We also need both external resources and domestic resources. The private sector needs to be well regulated and integrated into national systems, because otherwise there is a risk of further fragmentation that leads to inefficiencies and inequalities. As I described, the EU is deploying new financing instruments, and these instruments will only be successful if we put them at the service of great ideas and if these ideas are well implemented. So we count on you, we count on our development partners, and thank you very much.
Thanks, Mar. Yeah, and then we'll look forward to continue collaborating with you then in reporting about these potential partnerships and opportunities for local private stakeholders to work with the EU where it's most needed in health specifically. I'd like to bring in Anshu to the conversation, as the World Health Organization has been obviously on the spotlight for the past few months. And Anshu, you're the director for the reproductive, maternal, newborn, child, and adolescent health and aging at the World Health Organization. It's a long title, but I'm sure you have a great perspective on these resources that have been redirected away from regular health service delivery towards the COVID-19 response. In that context, and what role do you see for the local private provider, and how is WHO facilitating the process, or is WHO involved in facilitating the process there?
Thanks a lot. And maybe just to say that I think the other speakers have provided the background why it's so important to involve the private sector. So WHO has started up a private health sector for COVID initiative, and has done two things. One, it has sort of created an action plan, and secondly, it's looked at a number of bottlenecks in order for the private sector to be properly engaged, let's say. So looking at the action plan, it sort of has said, it's a 6-point action plan, but it said that we should work together. In order for that, we should be able also to know what kind of private sector assets can be used to increase the capacity to respond to COVID, we should be able to look at how public and private human resources can be used intertwinedly, let's say, and be working in different kind of capacities and institutions. At the same time, all facilities and staff need to have the supplies in order to be able to engage and to respond. And then the fifth area is around establishing systems to integrate public and private response in order to have the let's say the mechanisms there, and then also to make sure that there's financing in order to ensure access. And so when it looked at policy challenges, basically the first one was that countries were actually not sure how to best include the private sector in planning for the national response. And so, for example, there are a number of countries where there is already existing private sector networks, where they already engage with them amongst themselves, and where they have engagement with the government. And so there it was much easier to pull in the private sector and engage them in the COVID response than in countries where this was done on an ad hoc basis, or where this hadn't been done at all. And so that was the first policy challenge, let's say. The second one was really around resource-based planning. And I think people have already highlighted this, that often we do not know which resources actually are available within the private sector. And so this basic lack of data is important, or is an important bottleneck, let's say, to overcome, in order to have an idea how many respirators, let's say, are available, how many staff are available with what kind of skills, etc. The third policy area or bottleneck was around the fact that the private health sector lacks certain resources and capacities for it to be really engaged or be an effective partner. So, for example, the government clinical protocols were not there, or medical staff were not updated and their capacities were not updated, or particular commodities such as drugs or testing kits were not available, or that PPE was not available. So that also was a challenge for the private sector then to be fully engaged. The fourth one was around emergency legislation that exists in country and therefore sometimes impedes that sort of, let's say, the engagement. So, for example, we have small pharmacies or small private sector providers who had, because already highlighted before, people were not coming anymore, so the demand reduced because people thought it was not safe to go, and so they would basically go bankrupt. And so there need to be policies in place to make sure that these private providers remain active and can survive, let's say, the pandemic crisis. At the same time, also, we had issues around market pricing. So, for example, government said that if you treat a COVID patient, this is what we can reimburse you, and it would be way too low compared to the actual price. And so then you create a perverse incentive for the private sector actually to not diagnose someone as COVID, because they would not get reimbursed what they would spend. And so that would also impede or be have a negative impact on the response to the pandemic. The other issue is, for example, that there would be HR policies that retired people couldn't be brought back into the workplace, let's say, and so you'd have to look into that. So, and the other one was there where government actually incentivized the private sector to do testing. Often the private sector wouldn't report, and so then that didn't allow us to have a good idea of where the pandemic was and where the cases were. The fifth challenge highlighted was around financing. And so I've already highlighted one example, but for example, in certain countries, in-kind donations were provided, but not actually financial support. And for example, yeah, let me stop there. And let me give you just two examples where WHO has been active, let's say. So we have, with support from Merck for Mothers, we have been working in Ghana, looking really at how to engage the private sector. And with the GFF, we've been working in Ethiopia. And for example, in Ethiopia, the activity undertaken was really to engage the private sector association, the private providers association, to see how they can engage with the government and establish that dialogue to get them involved.
Great, thanks, Anshu. And I'll go back to these data points that you've mentioned, the data that you may need, the data that may lack from the private sector side. That's something Susan touched on as well in the conversation we had yesterday, to better engage with the private sector directly. Before we go there, I'd like to get the floor to Annie, and Annie's the Chief Investment Officer of the Grand Challenges Canada. And we've seen, and we're seeing now in the COVID crisis, how health innovations is important. And it's also very important in maternal health. And so we'd like to know how you're providing financings to health innovations in the private sector, and what impact do you see with it? So very briefly, Annie, if you can help us with that and see what type of data that you're sharing, what type of storytelling you're providing to help engage the right private sector stakeholders.
So for those who are less familiar with Grand Challenges Canada, what we do is we finance innovators with grants and loan and convertible loans. And that ranges from non-for-profit organizations that are looking to scale their new idea via a government or larger NGOs, but also social enterprises and technology startups that are developing new treatments, new medical devices, new technology platforms that are perhaps more efficient and can reach more people at the bottom of the pyramid. And our guiding principle is really that our capital has to go towards reaching people who need it the most in the country, and often that will involve working closely with government funders. In terms of how we do it, it's really about right capital for right activity. And so recently as last year, we looked to our framework and really tried to improve it in such a way that when we look at a social venture or a startup, we look at its valuation potential on one axis, and we look at the use of funds on the other axis to determine, for example, if we're looking at a technology platform that has large scale global potential, could be a huge win, we consider that very differently from a local hospital that is perhaps very early stage and only serving bottom of the pyramid populations. Similarly, we look at our activities. And if we're funding activities that are strictly focused on bottom of the pyramid or perhaps measurement and evaluation, we evaluate that very differently from collecting data for a clinical trial that serves to grow the company for the long term. And so that's really the input that our deal leads will consider in designing a financing structure for an innovation that comes on our desk. To answer your other question as well, why we think it's important to fund these social enterprise and startups, so to speak, because it can sometimes look at it a little odd from the outside in when we're trying to really focus on bottom of the pyramid populations. But why we think it's important is we see that private sector solutions are often aimed at being more efficient, doing more with less. They're often, what's interesting is our role can be catalytic in terms of making sure that the founders can, continue on their vision of reaching bottom of the pyramid populations, even whilst they raise private capital, because we know that they face pressure often from investors to, focus on the higher income populations. So our presence, as an investor in the venture can help with that. And the other piece that I should highlight is what we like about private sector solutions is that they can be very flexible on meeting the needs, whereas government providers, they have a basket of services that's been approved a long time ago by a heavier process, whereas the sort of smaller hospitals, the local pharmacies, they just meet the need. If they see a lot of patients come in with a certain need, they can just address it, and it's just done. So we like them for that reason, but we do wherever possible ensure that they plug into the greater ecosystem when we fund innovators. One piece towards the future perhaps that I could say is that where we see we fund very early stage innovation. So, there's a little bit of proof point. We help them gather more proof points so that they're ready to scale. And we do see a big gap in terms of financing for social enterprise and companies that can be impactful, so that they continue to have impact capital. And what we're really working on these days is launching investment vehicles that are both for philanthropic investors and for-profit impact investors to really provide capital at the seed, Series A, and Series B stage. And that's particularly important, we see, for those that are developing evidence-based solutions. So think about solutions that need FDA approval, but also larger technology platforms that can serve, I would say, greater needs for sort of system level improvements. I'll pause there.
Thanks, Annie. That's great to hear that you're supporting social entrepreneurs, and you work in over 100 countries with your since you started Grant Changes Canada. So it's a great inspiration there. I will definitely keep reporting on what you do and involve you in this conversation. I'd like to go to Desta, who's joining us from Kenya today. Desta Laku is Director of Partnerships and External Affairs at Amref Health Africa, which is one of the largest international NGOs based and headquartered in Africa. And Desta, it's great to have you and kind of close in this first round of comments on this, as you also work a lot in the ground with a lot of community health workers. And I'd like to put things back into perspective and maybe reflect on what Adoranke and others have touched on, and the role of the private sector to provide maternal quality healthcare, and how do you partner with the private sector as an NGO? And it'd be good to have your say on that.
Thank you very much, Alex. I hope you can hear me, and good evening, good morning to those of us, those of you who are on this call. I think Amref has sort of a unique position, and we're not a private sector, but we have been working for quite a long time with the private sector and also public sector. And when you think about who is the local private sector, Susan mentioned earlier that, we're still trying to define it and further clarify that. So we are doing that. So what we do is we actually work at the intersection of those who provide service, first level service, to those who have no service or hard to reach communities in general. And the difference, I think, for us as an NGO and a large NGO in Africa is that we actually work across the key pillars of the health system. So our partnerships are essentially aligned to what is needed across those key health, pillars in the health system. So, for example, when we look at the current pandemic, it's just shown us how fragile our health system is, and it's given us pause to think about not just how do we bridge the gap that's existing today with COVID, but how do we think more strategically and longer term with our partners to ensure that these gaps are managed for the long run. And we know that without primary care, we can't have UHC. So we have always believed in working with partners, looking at market-based solutions where possible, but really co-creating the partnership so that it works for the community first and foremost, and it is something that Amref can deliver on and meets the needs of the private sector partner, right? So our primary focus, since we're looking at health systems strengthening and the health system pillars, are training of frontline providers and health workers, for example. So this would include things like building the capacity of private providers on clinical protocols and updates. For example, now in COVID, in the current situation, we're ensuring that the primary care providers are receiving government guidelines and to address and adapt patient care as needed. So that's one area, which is a very big area for us, where we work with private sector partners and have been for quite some time before COVID, during COVID, and we continue to do so after COVID. So it's really training providers training frontline community health workers, training midwives, training traditional birth attendants, who are the ones who are referring, women in the community for INC and delivery services. So we work very closely across that level. That has not changed for us, and we continue with the same partners, and also now newer partners who are now providing support for PPEs, for example, because many of our community-based health workers especially are fearful. There is a stigma around COVID, and that impacts care delivery, and it impacts access to essential services. So we've seen that, and we are working very, very closely with the community to do risk communication and also delivery of PPE where possible, working, of course, closely with the ministries of health. I think more importantly, what we've seen in terms of the work we're doing with our partners are really around how we're now able to leverage technology to deliver, the training that's needed. So we're using mobile platforms that we already have in-house, for example, such as Leap and Jibu, but we're working very closely with the telecom industry. So when we think about private sector, it's not necessarily, a doctor who sits in an office somewhere waiting for a patient to walk in. It is actually all of those other industries that support the health space. So we work very closely with private sector like Safaricom, which is a Kenya-based company, to Orange, which is a more international telecom provider. And with them, for example, we provide, they provide network access for data collection. They provide support for telemedicine. We work with multinationals like Microsoft, who are providing us with platforms for communication across the different offices, the different regions, with our partners, etc. So we're leveraging mobile technology platforms and partners to jump in, not just for COVID, but certainly for COVID, but just longer term. Those are the partnerships that we have. So in this way, we're able to collect data, provide distance support, etc. Then, of course, and I don't know how much time I have, but we're working with other sectors also, those who are working in the water and sanitation area, companies such as Coca-Cola or others who are providing support for, water and hygiene. We are working with companies that are doing soap and hygiene manufacturing. In Kenya alone, if I can give you two examples that where we've really leveraged our partnerships and really transformed things. We've worked in Kenya. There's a project that we started with called Wheels for Life. It's a public-private partnership. We work with the government, we work with private sector, with foundations, with the Healthcare Federation, with media, fleet services and ambulances. And Wheels for Life actually specifically is focused on maternal care and access to maternal care for Kenyan women who are pregnant. So for example, since we launched this in end of April 26, we have already received over 12,000 calls. So this is, because of COVID, restricted time, curfews, etc. But you could call Wheels for Life and you can get access to antenatal services or delivery services. So since April, we've had more than 12,000 calls. We've had more than 1,000 women assisted by doctors, about 150 ambulance trips, over 500 cabs dispatched, etc. And all of these women, 90% of these were deliveries. So it's really, how do we act fast? How do we leverage partners, local partners as well as regional partners, to deliver service? So this is one sort of very specific example about Kenya. And then we have a more regional example with the National Business Compact on COVID, which I'm happy to go into, but that looks at a range of different partners that we're able to pull together. And these are partners that are not necessarily health related, but hygiene and soap manufacturing companies, communication companies, agencies and associations. So it's really leveraging the folks who are in, current partners and new, and aligning them to delivery of service.
Yeah, and it's really interesting. It really showcases how hard it is to capture the level of investment that's put in the private sector and by the private sector to help improve these maternal health goals. Because as you say, some of them are not the natural players that we can think of. When you mentioned Coca-Cola, I know the Global Fund has a partnership with them as well on supply chain, on sanitation. Looking at technology was important for you as well to talk about training capacity. It was one of the main conversations in some of the previous panels and the polls we've run. We only have 5 minutes before closing the conversation, so I'd like to bring in back Aderanke's perspective and really just a few words, maybe in a sentence or two. What's your takeaway from this conversation, and where do you see any opportunity for you to, or for your type of organizations to further partner with the donors that we have around the table? And then I'll ask a very quick question it's actually a very big question. I'll ask you to answer very shortly about what are some of the gaps you currently see standing in the way of the reporting of private sector engagement that you're doing and its impact. And so Aderanke, yeah, please, if you could just share your few initial comments on the conversation we had today.
Okay, thank you very much, Alex. I think it's been a very enlightening conversation, and seeing that organizations are becoming more open to partnering with with the private health facilities, seeing that they play a big role in the health system. And considering the data reporting, well, I think one thing that we've been able to achieve with the Integrate E project is the data reporting, and but one of the gaps, I think I'll talk about the gaps before I talk about the possible solution. When we started out the project, it was manual, there was this manual reporting where you had to fill in, anytime you attend to a client, you fill it in a book and all. But over time, as the project progressed, an app was developed. I think it's called the District Health Information System app, where you're able to upload your data. After you've gotten your data for the month, you upload the data on the app, and it's like a central database. So from that database, the reproductive health coordinator for the state can access the data there and collate the contribution of the private health facilities with that of the public health, so that you have a better picture of what is going on as regards family planning services. So I think one way is will be to digitize the system, pretty much like what the DHS app is doing. Make it less cumbersome. I don't know if there's a way you can make it as you seeing the client, you entering it into the system, it's going straight to the database. So there is a connecting, if there's a way to connect the public health facilities with the private health facilities. Because I think one of the challenges of data we have with data reporting now is that beyond providing the service to the client, the data reporting seems like a different job function. Some private health facilities actually have to employ a particular staff whose focus is on data reporting, so that they can adequately capture the entire data. But I believe that if there's a way that we can, like a central database, connect all the systems, so that as the service is being provided and you're imputing it, it's going straight to the database, make it less cumbersome. I think that's the word.
Thanks, Aderanke. Yeah, it looks like this issue of data gathering touches all of us at all levels of the global health and health response capacity. And well, I'm not sure we have the time to go through that last question. I wanted to ask you all about the reporting on the engagement of the private sector, because we have so many participants today. But maybe I invite Marianne to reflect back on that and share a call to action with all our participants today. We'll also keep reporting on these issues on a regular basis, but Marianne, do you want to go ahead, and do you want to ask this quick question to everyone, or just go for a call to action?
Sure. My big takeaway from this roundtable is we need to have a follow-up session. I feel that I have learned so much, about what is happening in each of your organizations that, I was not aware of. And I think that if that's the case for myself, it's probably also likely for a lot of other people not understanding the extent of work and collaboration, that's already happening. And to just link it back to Alex's original point about what happens next, what we are hoping is that we can figure out a way to collect this information in a way that's value add and actionable by stakeholders such as yourself. And so whether it's just, being able to understand the totality, of the diversity of collaborations with local private providers, whether it's being able to understand the totality and diversity of their contributions on the front line, whether it's able to understand what works and what doesn't work in terms of collaborations, and in terms of impact on health. I think that this is information that is very valuable. I know at least it's valuable to an organization like MSD for Mothers to inform the type of work we do, our strategy and our investments. I don't think any of us wants to recreate the wheel, or duplicate duplicate work that's already been done, when we can share and learn from each other. So in terms of next steps, I do think it would be helpful to hear back from all of you, around best ways, to kind of collate and share what we're doing and identify the types of data that is valuable to share. Because at the end of the day, we don't want to just be collecting for collecting's sake. We want to be collecting data that's valuable to each and every one of you. So thank you.
Marianne, maybe I could just make one invitation. USAID just spent the last year developing a private sector engagement evidence gap map, which was recently launched. It is a living document that we want to have people contribute, whether that's gray literature, whether that's project reports. And so that platform already exists, and we would welcome anyone to add to that. And I'm happy to share links out with people afterwards.
Thank you, Susan.
Oh, thank you,
That's
Susan.
exactly what we want to happen.
Yeah, and you can also share it, I guess, on social networks using hashtag on the Frontlines. And I'm pretty sure that our production colleagues, Julie and Natalie, have shared it on the Hopin platform where participants are joining from. So thank you, and thank you all for your time. And you all have very busy schedules, and do not have time to speak much at this conversation. But it's really easy to start to further engage you in conversations we'll have for the year to come. Really, almost 18 months to come, we'll be reporting on these issues on a regular basis to really try to help building sustainable local health ecosystems between private local stakeholders, public authorities, civil society organizations, and international players. So it's really what we're going to try doing, reporting on the funding that's made available in that space, try to engage all of the key stakeholders, and also take the opportunity to thank all of the other speakers, all of the DevEx colleagues, and our partners at MSD for Mothers, Smile Train, and J&J, who made that event possible. If you want to follow what's happening in this broader space or topic around health workers, we invite all participants to continue following the series Duty of Care. And if you want to really contribute to this work that we're doing on reducing maternal death and child death, follow the Maternity Matters series, Funding the Future, for big insights on funding around these issues. And we'll definitely follow up with you all at USAID, GFF, European Commission, Grant Challenges Canada, AMREF, WHO, and all partners who joined us today to make this this event a great starting point for conversations we'll have in the future. Thank you all.
Thank you. And
Thank
thank you for the
you.
work everybody's doing.
Thank you. Bye. Good
Thanks a lot. Thank you.
Thank
Bye.
you.
Bye.
Bye.